We are live now, ma'am.
Can I start? Yeah.
Yes, ma'am.
A very warm welcome to all the esteemed faculty members and the delegates who have joined in for today's program, the Benchmark Series by Dr. Sneha Buyar Madam. This is the sixth episode that we are going now. This focuses completely on hypoglycemia and pregnancy, and we have all the stalwarts in their fields, Dr. P.K. Saxena, Dr. Hema Devakar Madam, Dr. Uday Thanawala Sir, Dr. Sunil Gupta Sir, and Dr. Vidya Thobi Madam, who will be sharing their experiences and their thoughts with all the delegates so that we will be able to manage hyperglycemia in pregnancy in a much better way. I would like to introduce our convener for the program, Dr. Vidya Thobi Madam. She's been the president of KASOGA in the year 2023. She's also on the state advisory board of the PCP entity Karnataka. She's has been the chairperson of the Food, Drug and Medical Legal Surgical Equipment 2018 to 2020. She has won the Best Committee Award for the same. She has held various posts in ICOG as well as in KASOGA, and she has been the president of our Bijapur OBGY Society. We welcome you, ma'am, as a convener of the series.
Thank you very much.
I would also introduce Dr. Sneha Buyar Madam today. Madam is the brainchild behind this webinar series that we are witnessing. She is the past chairperson of the Foxy Breast Committee. She is also an ICOG governing member. She has been the chairperson of the AMOG's Emergency Obstetric Committee as well as the Medical Disorder Committee. We welcome you, ma'am, and I request all the faculty members to join us for the lamp lighting ceremony so that we can start the program.
Madam, to please introduce our chief guest. Vidya, ma'am.
Before that, Monica.
Yes, ma'am. Ma'am, you please welcome the delegates.
Yes.
Yes,
I will just give a welcome and a brief preamble about this program. Now I can see Madam Jayam Kanan. Pranam. So with lots of happiness and blessings, we are very happy to have you, madam. So a very good evening to one and all, respected Madam Jayam Kanan, and of course our chief guest for today's program, Madam Shalini Jackie, who's the endocrinologist. Of course, my respect and regards to all the seniors, and my special regards and thanks to Madam Hema Divakar for guiding me designing this wonderful program on hyperglycemia and pregnancy. I welcome all the respected faculties for today's program. Madam Hema Divakar, Dr. P.K. Saxena, Dr. Sunil Gupta, the endocrinologist from Nagpur, and also Dr. Uday Thanawala, who is the past ICOG chairperson, and Dr. Vidya Thobi, our past chairperson for the Food and Drug and Medical Surgical Equipment Committee. So I welcome all the faculties and chairpersons, Dr. Vaidehi Marathe, Dr. Pranjal Sharma, Dr. Mosmi Banerjee Dey, and Dr. Shuchi Jain, Dr. Bharti Maheshwari, Dr. Deepika, and of course, Professor Manju Verma and Supriya Jaswar, our dear friend, Dr. Manisha Gate, Dr. Manoj Aglave, and also I welcome Dr. Vidya, not only as a good friend and faculty, but the convener for today's program. I also welcome Dr. Monica Umbardhan, who is a very hard-working coordinator for all of us. So with God's blessings we have already received, and with the blessings of the seniors, we would like to start this program, and I declare that the inauguration is done. I would like to introduce the the convener has been already introduced, so I would like to hand over to you, Vidya, for the introduction of the chief guest.
Thank you, Dr. Sneha, and I welcome all the dignitaries, faculties, and the delegates for this benchmark session. And really, it is a benchmark session, and it is very designed very nicely by Dr. Sneha and guided by our dear Dr. Hema Divakar. So I welcome our chief guest today, Dr. Shalini Jaggi. She has joined from US, and it is a very early morning there, 5:30. And very good morning to you, Dr. Shalini. She is a consultant and director, Life Care Diabetes Center, New Delhi, governing council member, DIPSI, and chair-elect RSSDI Delhi chapter. Serving AACE advisory board member, diabetes and the lipid and cardiovascular health committees. And I think she has chaired many organization and recipient of many awards. And out of that, she's a recipient of RSSDI Women Diabetologist of the New Year, recently 2023. So over to Dr. Shalini to bless us or share her experiences especially the diabetes in pregnancy, how many cases she must have handled. Last time, it was very nice to hear you in one of the webinars. I really enjoyed your talk, Dr. Shalini. So over to you.
Thank you so much, ma'am. Good morning, everyone from US. And it's such a pleasure to be here with all the dignitaries and all my seniors and colleagues. So I pranams to all the senior dignitaries and faculties present here. Thank you, Hema ma'am. Thank you, Vidya ma'am. And thank you, Dr. Sneha, for having me. Dr. Picky, I see you there. It's such a pleasure to join this webinar, and I really did not want to miss it. I think hyperglycemia in pregnancy is something which is very close to all our hearts. All of us, I think, work together. We always say multidisciplinary approach. So I think this is exactly an example of what we always saying. We all of us have to join hands and help all our patients, detected with any form of hyperglycemia in pregnancy. And we know the numbers are rising, but I'm so happy that we're actively doing things to collaborate and help our patients as a team. So it's not only OBGYs or only diabetos and endos who are handling things, we're all working together. And I think all the complications that we say associated with hyperglycemia in pregnancy, most of us are able to prevent complications. And the whole idea of spreading awareness on this topic, educating all our colleagues on early detection, importance of screening for GDM or preconception counseling when it comes to women who already have diabetes and are planning pregnancy, and then how they should be managed during pregnancy, lactation, deliveries, everything. I think this holistic approach towards hyperglycemia in pregnancy is very important. And I thank all of you for being so proactive in educating everyone. So I think there's a lot to learn on this by mutually discussing these topics, and I can see such great topics and speakers. So I'm really excited to listen and learn from all our speakers. And thank you so much for having me there today.
Thank you so much, Dr. Shalini Jaggi. In fact, the first and foremost, I appreciate you for taking the pains to, get up at so early. I was thinking maybe towards the end of the program, you should join and we should be able to listen to you. But you are earlier than us. So appreciate you for all your punctuality and lots
Pleasure, ma'am. Honor for me. Honor for me to be part of this program, ma'am.
Thank you.
Thank you.
So,
Thank you very much.
With this, I would just, those who have joined for the first time on this program, I would just give some information that this is the 6th episode of this benchmark program. And the name benchmark I have selected just because that, it is a very focused program of that particular subject. And what we do is we just, prefer to have the authorities in the field of that particular subject to just to help all the Foxians to learn the topic thoroughly, and whatever expertise and experience these faculties can share with the Foxians will be of great help to them in their day-to-day practice as well. I welcome Madam Jayam Kannan for the second time on this forum, and it is my honor and privilege to introduce her. So Madam is not only the senior, respected senior, but inspiration and blessings to all of us. Madam is an emeritus professor of Tamil Nadu MGR Medical College University, Vice President of Foxy 2018, and of course PN NCF WHO since 2008. Certificate course in reproductive medicine, Foxy since 2012. I think she's completed. She has organized President of India Medal for outstanding performance in MBBS. Also, the state first in MBBS, Al-Mudliar Award in MD.
Thank you, Sneha. Thank you, Sneha.
Madam, it is only to inspire the younger generation. I have to read all this. And rather than spending time, I would prefer listening to you, Madam. Thank you.
Thank you, Sneha. Of course, hyperglycemia or diabetes in pregnancy means Hema Divakar for me. The last decade saw so much about the South, especially Professor Sheshaya, who has done work on more than 1 lakh of antenatal patients. Even though at that time, Dr. Ramachandran and others were also very active in diabetes, it was Professor Sheshaya who spent nearly 30 years of his life, and now today Government of India has accepted it as a base. I won't say it is a high end, it is a base. Over that, Sheshaya always used to say, 20 years ago, right from now, 20 years ago, in one of the physicians' conference, there were 2 gynecologists. One was Hema Divakar, another was Desing from Orissa. Okay, so from 2004-5 onwards, she has been into this, and the various names given to diabetes, dipsy, hip, this, that, and all these things are going on, but still the problems continue. I'm very happy to see that Hema is doing her best in this present decade, along with people like Shalini and others who are there to get our women in diabetes. But for this hue and cry which has been created by Foxy and this thing, Dr. Sheshaya and the Government of India giving guidance in 2014 itself on please care your pregnant women with first itself and the first visit itself of blood sugar is the one which has made us avoid so many intrauterine deaths. Of late, of course, we are hearing it is not 140 or 130, it is 110 at 8 weeks. I don't know what Hema is going to say about it. And at 6 weeks itself, you find out somebody is above 105, 2 hours postprandial, 110, 2 hours postprandial. Please be careful with them. This is what we are getting because the pancreas is going to develop only after that. And the stimulus is given by the maternal hyperglycemia. So all these things are going to be discussed by all of you. As a senior, I just bless you on this Guru Vachara day. As Baba's evening Aarati is going on upstairs, I am sitting down near Chavadi Baba's place and send all his blessings to all of you for all your achievements in Foxy and for the future of your life. Thank you very much. Have a great day today.
Thank you so much, Madam.
Thank you. Over to the organizer.
Thank you so much for your words of blessings and guidance. I'm very happy to have both the guests, very learned faculties of the field, and thank you so much, all of you, for joining this program. And I take this opportunity to thank all the dignitaries, especially Dr. Shalini Jaggi, who's joining all the way from US, Madam Jayam Kannan from the Baba's Aarti. She had, specially joined for us. And Thursdays, Madam don't join, but with my request, I'm sure Madam will not deny and get lots of blessings for all of us. All the faculties, Madam Hema Divakar, Dr. P.K. Saxena, Dr. Sunil Gupta, and of course, Dr. Uday Thanawala and Dr. Vidya Thobi, all the chairpersons, I have already welcomed you. Thanks for joining and thank you. Be there. I'm sure it's going to be a very delightful and very important session. Lots of learning from this session. Over to you, Dr. Monica, for the academic session. Thank you so much, all of you. And of course, keep blessing me. I don't like to urge and make appeal all the time. Vote for me, vote for me. I know you, I'm in your heart and you're going to bless me. Thank you so much.
Thank you, ma'am, for allowing me to coordinate this program. I declare that the inauguration is now over and we now move forward to the first session. The chairpersons for today's session are Dr. Vaidehi Marathi Madam and Dr. Pranjal Sharma Madam. With the speaker, Dr. P.K. Saxena Madam, speaking on new thoughts on to prevent diabetes. Can we have the chairperson's inauguration slide? Dr. Vaidehi Marathi Madam has won the Master's Signature International Award twice. She is the first in Maharashtra.
Monica, we can skip our introduction can be skipped, so that we save time.
Madam has been very active in the Public Awareness Committee regions in AMOX, and she has been very socially also involved in lots of activities, including menstrual hygiene. We welcome you, ma'am.
Thank you.
I would like to introduce Dr. Pranjal Sharma, madam. She is the immediate past president of the Amravati Society.
Same thing, you can skip, please.
Yes, ma'am. By the way, ma'am, I would like you to introduce our faculty, and Pranjal, madam, would you be able to sum up the talk at the end of the session?
Sure.
I would just like to say that very, very proactive obstetrician and gynecologists from our region of Vidarbha, who are not only active in academics, but also very, very active in the public awareness, sensitizing the public health education, which is so very important, not only the academics. Thank you so much, Chairperson, for joining them.
Thank you so much, ma'am. I must congratulate you, the lady behind this benchmark series. I mean, it's such an innovative and the perfect name for this program, Benchmark. I was wondering why I did not think of this name when I was the president. Then we would really break our heads over, thinking of some innovative names. So it is a wonderful initiative. Thank you, conveners, Dr. Thobi ma'am and Dr. Monica, for inviting me here today, along with my co-chairperson, Dr. Pranjal. I'm very happy to introduce today's first speaker, Dr. P.K. Saxena ma'am, who's the head and director of the Department of OBGYN LHMC New Delhi, India. And we have heard of people winning a lot of gold medals, 5, 10, 15 maybe, but she's the winner of not 5, 10, 15, but 34 gold medals. And she's a true academician, having edited multiple books, been a chairperson of Infertility Reproductive Committee of AOGD. She is been the General Secretary of Board of Management of Delhi Diabetic Forum as well, which is just appropriate for this today's program. She has released many books. She's been editor of many books, and the CV is really very, very impressive.
Thank you.
Very, very impressed, ma'am. So we are so happy to have you here. And I was thinking there's going to be some senior person coming in because she's the HOD, but you look very young. So very happy to have such a charismatic and a charming personality with us. I welcome you. The floor is all yours, ma'am.
Thank you so much for such a warm welcome. Am I audible? There was some problem with my...
Yes, you are audible, ma'am.
Now.
And my slides are visible now?
Yes, visible.
Okay. So first of all, I would like to thank Dr. Sneha, Dr. Vidya Thobi, Dr. Monica, and of course, my most favorite Dr. Hema Divakar for giving me an opportunity to be here amongst this August gathering. And I think I congratulate Dr. Sneha for choosing such appropriate, such correct and pertinent topics and speakers for the program. And today I will be talking on new thoughts on to prevent diabetes. Just a minute, there is some problem in my screen. Just a So we have come a long way. There have been so many changes since the time we were doing PG. There was only one condition, which was gestational diabetes. Any type of hyperglycemia in pregnancy used to be known as gestational diabetes mellitus. But now there is a change in focus. FIGO has correctly defined hyperglycemia in pregnancy into two categories: the diabetes in pregnancy and the gestational diabetes mellitus. There is a lot of confusion regarding this. Diabetes in pregnancy is also known as pre-gestational diabetes or overt diabetes. It may be type 1 or type 2. And when do we say it is diabetes in pregnancy? When the fasting blood glucose is more than equal to 126, or if the random 2-hour post-glucose or postprandial value, anytime it comes more than equal to 200, then it is known as diabetes in pregnancy, which is the same as I just described with the pre-gestational or overt diabetes. And this can be diagnosed before pregnancy occurs, during pregnancy, after pregnancy, and in non-pregnant patients. So we need to remember what is diabetes in pregnancy. If during pregnancy, the threshold of blood glucose is more than 140 but less than this, that is between 140 to 199, then we say that the woman has gestational diabetes mellitus. And now the thoughts have changed. It is not just during the second half of pregnancy, it can occur during the first trimester itself. My slide is not moving here. So there has been a tremendous change in the purpose of screening. First, we used to think that we need to screen and pick up diabetes in order to prevent adverse feto-maternal complications. But now, today we understand that GDM is the mother of all NCDs which are going to occur in the future generation. So the focus has changed to the primordial prevention of not just GDM, but diabetes and the other NCDs. And we need to focus on the adolescents and during the preconception period. Anytime a girl is coming to us in the infertility clinic, adolescent clinic, we need to take charge and do her blood sugars, weight, BP, and aim for primordial prevention of not just GDM, but also diabetes. We need to understand that GDM is not a transient condition, but it is recognized as a stress test, which indicates physiological dysfunction. This graph that I'm showing, I'll take this pointer. So in this, you can see then when the beta cell dysfunction is about 10 to 15%, then it manifests as impaired glucose tolerance in non-pregnant patients, and the same manifests as GDM in pregnancy. The importance of GDM is that nearly 2/3 of these women are going to develop GDM subsequently, and with age, the beta cell dysfunction is going to become worsened, and the 50 to 70% will develop type 2 diabetes within 2 to 5 years. Maternal hyperglycemia sets off a vicious cycle, which will affect not only the mother, but her baby and also the future generations to come. Therefore, GDM offers a unique opportunity for initiation of strategies for preventing not just the immediate pregnancy complications, but diabetes prevention later on in life. This is the landmark HAPO study on which the IADPSG, that is the International Association of Pregnancy Study Group Criteria, is based on, which was done on 23,000 women, and it was seen that the continuous positive correlation was present between maternal plasma glucose levels and the adverse feto-maternal outcome. Here it is important to note that adverse maternal and fetal outcomes were observed even at levels below the diagnostic thresholds, which were set up at 1.75 odds ratio. So this is a very important paper which was published in ADA, published by ADA, where they considered whether the current therapeutic targets should be challenged. So Hernandez et al. Did a study where they pooled the analysis of normoglycemic women over 12 studies involving 45 years of data. And they found that the threshold for fasting should be reduced to 71 plus minus 8, and 2 hours postprandial should be reduced to less than 110. In sync with this, the latest revised DIPSI guidelines were released last year in August 2023. We all know GDM, when 2 hours plasma glucose after 75 gram oral glucose challenge is more than 140 or more, we say that she is prone to adverse fetal-maternal outcomes and type 2 diabetes also. But now it is recognized that there is an entity called gestational glucose intolerance, where if the threshold is between 121 to 139, they have similar outcome as GDM. So this is another entity, and we have to reduce the threshold from 140 to 120. We need to pay special attention to this group also. Now, the most important focus of attention is on early gestational glucose intolerance. That is the group of women at 8 to 12 weeks when the 2-hour postprandial blood glucose comes out to be more than equal to 110. And it has been hypothesized that these women are prone to develop GDM. And this is our target group for primordial prevention of diabetes. So I'm now going to talk about a very important concept, which is the fetal glucose steal theory. So we know, as Madam Kannan was saying, the pancreas develop at about 10 to 11 weeks of gestation. If the mother has hyperglycemia more than 110 at this time, it will pass through the placenta and stimulate the pancreas of the baby to produce more insulin. Insulin, being an anabolic hormone, is going to cause lipid deposition and macrosomia. It is going to cause early metabolic imprinting. And when the baby grows up in life, he will develop type 2 diabetes and other NCD. So other concept is that when the baby develops fetal hyperinsulinemia, it is going to pull up the mother's glucose from a higher concentration to a lower concentration towards the baby through the placenta, and thus in this way it is going to lower down the maternal glucose levels. And this phenomena is the underappreciated but very important fetal glucose steal. If we do the blood glucose level for the mother at this time, these levels will appear to be normal, although so many times we have come across women who are having polyhydramnios, macrosomia, but blood glucose levels are normal. So probably the fetal glucose steal phenomena explains. The early metabolic imprinting, which is affecting causing the intrauterine programming, is what is described by the Barker hypothesis, and it states that the adult disease originates in fetal life. So, as we all know, the concept of primordial prevention of diabetes was given by our guru, Padam Shri Professor Dr. B. Sashaya. So, he gave me the task to provide evidence to the concept given by him of early gestational glucose tolerance. And we did this study in Lady Hardinge Medical College, New Delhi, to evaluate whether first trimester 2 hours postprandial blood glucose of more than 110 is able to predict GDM. So we recruited women between 8 to 11 weeks, and we did a 2 hours post glucose level for them, and we also did a HbA1c. We did a GDM screening for all these women in the early second trimester, 24 to 28 weeks, and also in the third trimester. If any time the woman came out to be GDM, no repeat testing was done, and she was treated as per standard protocol. It was really amazing for us to see that 51%, that is 97 out of 189, developed GDM in this population. In the woman who had hyperglycemia of more than 110, 95% developed GDM. Whereas in the lower glucose group, only 4, that is 4% developed GDM. When we calculated the diagnostic accuracy, sensitivity, specificity, positive and negative predictive value, we found that 2 hours postprandial of more than 110 had a diagnostic accuracy of 95.88%. And the area under the ROC curve was as great as 0.969. Here you can see it is accurately predicting GDM in all cases. When we compare it with the expensive test, which is not feasible to do, HbA1c, we find that also has a good sensitivity, but it is only between 80 to 85%, whereas this physiological test, which can be even done by a glucometer by the A&M in the periphery or by the patient at home as a point of care test, has a sensitivity of 95%. The DIPSI group go on to say that if the blood glucose values is more than 110 at 8 weeks, these women should be started on medical nutrition therapy and low dose of metformin to bring the glucose level less than 110 at 10 to 11 weeks to prevent intrauterine programming. So the aim is that if at 8 weeks the postprandial blood glucose is more than 110, we need to give the intervention in the form of MNT and medical nutrition therapy, so that we have a grace period of 2 weeks till 11 weeks, 8 to 10 or 11 weeks, so that we can bring this level to less than 110. If it comes below this level, there will be no increase in fetal beta cell insulin secretion. However, if the level is more than 110, there is not enough time available to bring it less than 110, and the fetal beta cells start secreting insulin. We know that most of the organogenesis of the baby is over by 8 weeks. So starting metformin after 8 weeks is not going to have any problem on the organogenesis. And the recent guidelines say that metformin is safe in the embryonic stage and can be started from preconception to till confinement. So this is the ongoing study we are doing in Lady Harding. To one group, we are giving metformin. To the other group, we are not giving metformin. And here you will be happy to see that only 1.6% patients, 2 out of 119 developed GDM, whereas in the non-metformin group, 99 out of 117 women who had blood glucose more than 110 developed GDM. The focus has also shifted on the method of screening from ACOG two-step to all the newer guidelines recommending universal screening. And the government of India very aptly said that we need to adopt DIPSI as the universal test to be done for all pregnant women, because two-step test will miss, the ACOG criteria will miss nearly 25% of these. This test, DIPSI test, can be done irrespective of fasting status, and it can be done in the first visit, even if the woman has eaten some food. So there are less chances of having the patient to follow up. It is easy, convenient, feasible, and serves both as a screening and a diagnostic procedure. It is very easy to do. The other important thing is from bench to bedside. There is a change from venous sampling. We can do a point of care testing by glucometer. And it has been seen that the capillary blood glucose measured by glucometer has a very good sensitivity and specificity as compared to venous plasma glucose. And this has been recommended by the national guidelines and also by FIGO to be used in the periphery. So, and we also have the new innovation. Dr. Hima ma'am always talks about the technology, the new technology. Now we have a continuous glucose monitoring system in the form of the simple ambulatory glucose profile flash glucose monitoring system, in which we are getting blood glucose levels of the interstitial blood after every 15 minutes, and we can get a continuous graph. And we did this study in Lady Harding, and we found that at least 1/3 of the duration of hypoglycemia was missed when we were doing only self-monitoring of blood glucose by glucometer. And 92% of our GDM women out of 70 had hypoglycemic episodes, which was missed. Only 45% in our SMBG group had hypoglycemia. And the glycemic variability, which is a new dimension of hyperglycemia, this is another breakthrough. We used to think that the blood glucose levels are normal, HbA1c is normal. Why is the woman still having so many fetal-maternal complications? So now it is clear that glycemic variability, that is the peaks and the troughs. If we have too much of variation between the peaks and the troughs, this is known as glycemic variation in the day-to-day levels. And the aim is to maintain the levels in reduce the glycemic variability. Aim is to keep the average blood glucose levels plus minus 10 or 15. That is why it was advocated that 3 major meals and 3 snacks should be given, so that you don't have very high levels and very low levels. Also, from selective screening, we have made a change, and we are now doing universal screening, which is the apt for our country. The Indian women are 11 times more prone to develop impaired glucose tolerance. So universal screening is recommended by national guidelines, by Cochrane review, and by FICO. Another important change is, if you will recollect, that in our textbooks we used to read that GDM testing should be done at 24 to 28, because the placenta is big at that time, maximum glucogenic hormones are being produced, so we will not miss any patient. But now just see at this data. Before 12 weeks, 41% patients are picked up. Between 13 to 23 weeks, 20%. So if we do the conventional testing at 24 to 28, 30 weeks, we are going to miss these 62%. And also beyond 30 weeks, all those women who are obese, who had PCOS, who are hypertensive, who had previous history of GDM, previous macrosomia, abortions, medical comorbidities, they should be tested also in the third trimester so that we do not miss any patient. This is a very interesting study we did at Lady Harding in 800 women, where we compared the DIPSI test with WHO GTT and HbA1c, and we again found the diagnostic accuracy of DIPSI to be 98%, and the agreement between the two tests was very good. Another study where we compared the diagnostic accuracy of DIPSI with ACGOG, both Carpenter-Houston and the age-old NDDG criteria. We did this study in Lady Harding in 1,029 women, and by DIPSI we got the prevalence of 10.4%, by Carpenter-Houston 6.4%, and by NDDG only 3.1%. So NDDG is missing these 50% of patients which are being picked up by Carpenter. This was the first study where we also found that DIPSI correlated with feto-maternal outcome, and the diagnostic accuracy of DIPSI with both the ACOG criteria was more than 95%. Another change from conventional to designer insulins. Now we have the Lispro aspart insulin, which we take just with meals, and there are less chances of post-meal hypoglycemia. We have the basal insulins, which is the NPH, Detamir, and Digludac has also been approved by the DCGI last year. There are innovations going on, and research led by Sydney University, they are developing nanotechnology to provide very soon oral insulin to us. Another very important regulatory approval has come. Till now, metformin was not approved by any of the regulatory authorities across the world. But now the most stringent authority, that is the European Union, has given clearance, and metformin has been approved as the first oral anti-diabetic medication to be used safely from conception to birth. We have been using it in our PCOS patients, and in India, we have a good experience with metformin. So this is now endorsed by this body or regulatory body also. Another important thing is that postpartum care is now being fully recognized and giving due importance. The FICO says that a follow-up of during postpartum period in women with GDM provides an important platform to initiate preventive strategies which we had started during pregnancy, and to continue them to prevent obesity, metabolic syndrome, diabetes, hypertension. And we need to, at this time, refer the patients who are having impaired fasting, impaired glucose tolerance, or diabetes to our colleagues, the physicians, diabetologists, endocrinologists, nutritionists, and the diabetes educators. The babies who are born to the mothers with GDM need to be marked separately at high risk, and the pediatricians should follow these patients very closely so that they can have a close look. All these things FICO has very nicely enumerated have to be concentrated on during the postpartum period. So we need to recognize that hyperglycemia in pregnancy is a global health problem. It is a slow motion disaster, and 2 of the 3 deaths globally occurring are attributable to NCD. Non-communicable diseases are programmed and imprinted during pregnancy. So the diagnosis and management of hyperglycemia in pregnancy may help to turn the tide of diabetes NCD pandemic. As Dr. Hima ma'am says, it all begins in the utero, and we need to focus on the fetus for the future and join hands with other physicians and other specialists to bring down to a goal, to make our goal from prevention of adverse effects to primordial prevention, which is the dream of all the physicians. Thank you very much. These are some of my books, and thank you for your patience.
Pranjal ma'am, over to you.
Actually, hyperglycemia is one of the condition where we all obstetrician has to be critically investigative. We should not leave any stone unturned. That is rather we should take it as an opportunity. I must congratulate Dr. Sneha madam. She's pursuing this subject slowly since last 2-3 years, and she has really sensitized most of the our members for going well with this subject. And about Dr. Piki, you have covered this subject so well. You have covered all the points, rather the primordial prevention, the fetal glucose still, everything you have covered so well. So really, we all are enriched. Congratulations, team, for this wonderful presentation.
Neha ma'am.
Yes, thank you so much, Chairperson, first of all, for your wonderful inputs as well. Piki, naturally, I mean, you all are the masters of the subject, and the way you have, started off right from how the concept of the high risk screening was there, that how you have to change to universal screening, how only the the diabetogenic situation or etiology of the pregnancy, as you said, only during second trimester onwards. We used to think previously how you should start it, the screening at the very first point of contact. You have taken us through the journey of GDM, I would say. So hearty congratulations to you, and heartfelt thanks to you as well. Thank you so much. We can go ahead.
Yes, ma'am. Moving on to the next session by none other than Dr. Hema Divakar madam herself. Our chairpersons for today's session are Dr. Mausami Banerjee and Dr. Suchi Jain madam. Dr. Mausami Banerjee is a consultant gynecologist at the ESI hospital. She is the president of the Bengal OB. She is also the vice president of IMA Calcutta branch and the organizing secretary of the Bengal Society Conference. Yes, ma'am.
It's okay,
We welcome you, ma'am, to chair this session. The next chairperson, Dr. Suchi Jain, madam, is a professor and HOD at the Sevagram Varda College, associated with various institutions and the Lakshya ICMR WHO series. She is also a PG teacher and examiner of MUHS and DNB. She has received the late Dr. Praveen Mehta Fellowship in Endoscopy, and she has various publications to her credit. We welcome both of you. I request Mausami ma'am to please introduce Dr. Hema Divakar ma'am.
It's my proud privilege and great honor to get an opportunity to chair such an important session when Dr. Hema Divakar is a speaker. And at the same time, I must thank Dr. Sneha madam for this wonderful session and for sensitizing this hyperglycemia in pregnancy, and the convener Vidya madam and Dr. Monica. And really waiting to hear the whole of the session. We all know Dr. Hema Divakar. Basically, she doesn't need any introduction. She's the medical director of Divakar Specialty Hospital, senior consultant of OB-GYN, CEO and chairman, Asian Research Training Institute for Skill Transfer, Dean KCOG, Vice President Karnataka AHPI, Chair of Well Woman Healthcare FIGO, President Dipsy, ex-Vice Chair for FIGO PNCD Committee, past President of FOXY 2013, and advocate for delivering quality healthcare and opinion issues relating to women's health. And she also won a number of awards and recognitions. FIGO Woman Achiever Award in 2015, Global Asian of the Year 2018, CME Excellence Award for Artist Next Brand Award for artists for her
CSR Times Award and CSR Impact Award for Divakar Service Trust. So we are waiting to hear you, Madam, on a very important topic. Can technology help us to manage GDM better?
Thank you, Moshmi and Suchi. Thank you very much for chairing this session. And this session got cooked up so rapidly, all because of Sneha, which literally means sneh or friendship. All my very beloved friends in the faculty very quickly agreed to come. And then the other pillar is Vidya. They are all so passionate to share knowledge that, yes, if Vidya would call, then why would they not come? So that was the combination which put us together. And Monica, oh my darling, is always there to take us through quick connects and collaborates. And really, it was a fact that time and again, we are speaking on the bitter truth about this sweet disease, but there are so many angles to it, including the one which Piki just presented, and the next which Sunilji will tell us again and again. You know, the last bit, the last component of what if she needs insulin. We are all little skeptical. Metformin comes easily to our pen because we are writing for many other reasons, but when it's insulin, it's really not our forte, and how that is. And ultrasound as the sixth sense, which Uday is going to tell, and of course, the main issue about medical nutrition therapy, how to get that together. So when so many things are involved, how are we, with the time constraints that we all have all the time, manage to take care of our patients in the best possible manner? So that's where, like how we are speaking to each other, Shesha, sir, and myself know that when we instituted the certification course through DIPSI to empower all the OBGYNs to manage GDM better, both in terms of testing and caring for our women before, beyond pregnancy as well. It was so very difficult to reach every nook and corner, but still we took the efforts for those physical meetings. And now you see the power of technology. At the drop of a hat, Sneha signals that let's get together. We need to discuss this issue again. And we are all here speaking to each other, learning more from each other, and doing our best. That's the power of technology. And I can't start any of the deliberations on hyperglycemia in pregnancy without my salute to Professor Sheshaya, because it was only because I fought with him very, very bitterly. No, sir, how? And, lots of questions I raised as to how we as women's healthcare specialists can get into the forte of diabetologists. How can we make this complex situation a little bit more simpler to our minds? And step by step, the guidance and the inspiration that we received from this great man is always to be cherished and remembered. And therefore, his birthday on the 10th of March, grandly celebrated as the GDM Awareness Day by many, many mothers and children who are living today and healthy because of the initiatives that he has taken. Coming to, can we do better than what we always, the pursuit of excellence is, we make excuses that we have our limitations. We know our country is very diverse. We know the last mile is hard to reach. We know this, that, and the other, that multi-speciality is a dream for many small and middle-sized nursing home owners. Can Femtech help us manage GDM better? So the Femtech revolution, which is the digital innovation in women's healthcare space, reaching every girl, every woman, that's the dream. And we need to reach so many women, because just look at 6 out of 10 having anemia, 7 out of 10 facing diabetes, hypertension. The numbers are mind-boggling. And if we really, like feet on street, you go everywhere, that's not going to be either for awareness or for advice. It's going to be a most nightmarish challenge, if you may ask me. As it is, the access, affordability, and the quality of care, poor things are coming from such distances, queuing up here, and within 4 hours, the outpatient schedule has to get over because the same consultant has to run for many more things in our own setup. 2 minutes that this patient gets, whether which part we are seeing and what we are advising her, it's just such a huge challenge. And these numbers, these pictures speak for themselves. So the best and the only one-to-one way, maybe even in anonymous and a virtual way, the last mile could be reached by the technology. So Femtech, what is it all about? We had a state meet in Karnataka, in Bijapur, led by Dr. Vidya Thobe, and we said, we'll do a survey with the OBGYNs. And 56% of them said, Femtech? What is it? We've never heard of it. But the simple thing is that it is technology for women's health. That is Femtech. The word was coined by Ida, who introduced the first app for menstrual cycle tracking called the Clue. And many OBGYNs, as in all of us, also believe that health tech will be the future. Are women using it? Oh, yes. Whether it's the movie ticket or the Make My Trip or the hotel bookings or the apparels or the online shopping, for anything and everything, it's the technology. But are we using it enough as healthcare providers to connect with our patients and to do lot many more things that it has a potential? No, maybe, and we are slowly getting there, but not quite. Only 1/10 of the respondents said that they're actually using these tools. So recently, Professor Hood and the current FIGO president, and Kiera Michael Gary, and myself put up this article on the Femtech revolution, which is a new approach to pregnancy management by digital transformation. This is published in the International Journal of ONG, where also the surveys within our own country by major IT segment like Accenture, etc., have said that physicians are not promoting the digital engagement enough. They have a barrier in their mind, a setback, that nothing can match the touch and feel. Just like how we started with the single-step non-fasting test, where we recognized that the fasting and 4 pricks in the same women was not easy to do in the far-to-reach areas in our own country. So our own Indian jugaad, as how it started, landed up in a single step, which the world is accepting now. The same way, yes, touch and feel is important, but the single step test is a proof that something is better than nothing, and it turned out to be a real good thing. The same way where women anyways cannot have the multi-speciality care or reach the specialists from remote areas, when something is better than nothing, then you can't bask on your glory of the physical meeting and touch and feel. There could always be a hybrid version where you can use the technology to its best. Again, knowledge, attitude, and practices of specialist healthcare providers on Femtech. This was our cross-sectional study, which was published in the ACTA recently. This is how the digital India is. You go to any roadside vendor also, you will have a QR code and you can do a digital transaction. Everybody and anybody almost is using the mobile phones, and we have more than thousands in millions of mobile users. So when we say your health is in your hands, we literally mean that, because everything can be guided through the mobile. So the future of women's healthcare, as how you see in this FIGO Wellness Wheel, 2 concepts we want to drive home. One is the concept of the wellness across life course. Don't leave everything to the pregnancy stage. There is a phase of her life, pre-pregnancy and beyond pregnancy as well. Prepare her always for the next phase of her life. Anemia, yes, you could have cared for her before pregnancy or in adolescence. You want to now quick fix only when she gets pregnant. That is the target that we get, but we should work towards integrating the healthcare at every touch point. If she comes for any reason, if she comes for anemia, also inquire about heavy menstrual bleeding. If she's of the right age group, also ask about HPV vaccine. So don't lose an opportunity to do the best. So that is one concept we are driving on the FIGO Wellness Wheels, which is the Wellness on Wheels, which we showcased at the Paris Congress, and the future of women's healthcare through technology. And India is leading the way by leaps and bounds through the technological developments which nobody else in the world would have imagined that we would leapfrog to that extent and use it so extensively in every nook and corner of our country. The COVID came to our rescue with the telemed being out of necessity, quickly accepted by the healthcare providers. So now what better can we do in the GDM management? The variables, the planning of scheduling of appointments, the travel time decrease, the remote distance, the reaching the unreached, also can consult an online doctor. They can take second opinions. They can do anything and everything on the digital platform. The main role in gestational diabetes is the use of remote monitoring device, the glucose tracking apps, and the personalized dietary and exercise plan. This picture, actually, I go back there because you can see that in the villages we have established called our health centers, where these whom you see there are called the Swasthya Sakhis. All that they need to do is one prick for checking the glucose level, the HemoQ they use for hemoglobin, digital BP apparatus, and the weighing scale for the BMI. So all this is doable by anybody who is semi-skilled, and they can connect to us with all the readings and make the patient speak to us on the video, including the promotion and support from the providers to encourage the uptake of all of these is the need of the hour. That is why we are seeding the thoughts of, guys, the technology is right around you. Open up your mind to start using it more often than you have already been doing. The devices which are likely to now come, Picky has already alluded to it. The Visme is another device which we have been speaking about it since a year. It's ripe and ready to be imported into India from Israel. It's just like a bangle where the 24-hour non-invasive glucose monitoring can be done. So the recording and the availability of data on the Bluetooth can immensely help the guiding physician to do better than the best. Similarly, we all grumble that though the diet consultation and counseling is important, somehow it is pushed under the carpet. We have to take a dietary recall, we have to guide her, but how to do it in the shortest possible time that is available to us? By the time she looks up and down at the floor and starts telling you what she eats for breakfast, what for lunch, etc., all this can easily be filled into the Google form, for example, and also somebody else can do it. The task shifting, which we do in Manyata, the frontline healthcare providers, your assistants, your staff nurses, and in local languages also this is available. So that is what they would take as the daily recall. So by the time she comes to you, you know what she's eating is right or not. A FIGO nutrition checklist, which is a very, very, very simple checklist, which just checks whether you're vegetarian or non-vegetarian, because that's the starting point for many of the other questions that you would ask. Height, weight, and BMI, that's on the first page. And then the dietary groups, the frequency, and the portion size. With this, it just takes 2 to 5 minutes to do this exercise of the checkbox of the FIGO nutrition checklist. Glaring gaps will be available to you within the 5 minutes after doing this. Again, I bring to your notice, it can be done by anybody else in your setup, but the information is available to you to guide the patient further. When we did this study, again, implementing the FIGO guidelines in the low middle income countries, such as India, it was a multicentric study where many people said it's very, very easy to use. And were they using any kind of dietary history and recall before the simple tool was introduced? Yeah, sometimes maybe this, that, very mixed answers were there. What next after that? Again, the time saving will be to refer her to the apps after explaining to her the principles of the portion size, the frequent meals, the less carbohydrates, no bakery and sweet items, and high protein. With this understanding, she will be able to, most of them, even then, another 10 years, it's going to be even easier because they will figure out for themselves what to do. And there's also many literature support and reviews that even the dietitians are now leaning more on the apps because of the individualized guidance that they can give. Another important reason, we think that we can coolly announce that she has high sugars in pregnancy, but the kind of stress that it causes her, the anxiety that it provokes, and she has nowhere to go, there again, the technology and the apps help. We have instituted a course by the Health Sector Skill Council for the mental health and well-being, because there's a huge demand for this course for their back-end employment by the app makers. So one of your staff gets into this course, gets a certification by HSSC, she takes the calls through the app, which is guided to her, 200 rupees per call, her livelihood and incentive is also done, and she knows her limitations. She at least checks the initial issues and then flags it to the consultant. So this is again in an anonymous and confidential way. In their own language, the patients can be tackled, because we need not be the ones to do it all, but we can make this available through technology to each and every patient of ours. The hybrid perinatal clinic is our concept, which we are really toying that many of the Digi Swasthya clinics should be the dream come to reality in clusters of 20 villages in many districts. At the block level, the Swasthya ambassadors need to go and check for the best that they can do. Wearables act as an additional layer of vigilance, complementing the prenatal care and enhancing the overall quality of maternal care. At the moment, things may not be very affordable, but the volumes are increasing. Anybody and everybody thinks the television and the mobile is much of a priority than anything else that they own. So slowly it is coming into the picture. And these fetuses will require repeated monitoring. Just if you can imagine that the CTG has to be done twice a week, and the big machines that we typically have can be replaced by the small device called the baby beat. What we do at our hospital is to rent it out to the patient, because then she need not come, as frequently as we would want her to come. We teach her how to use it. It just takes 2 minutes to teach, and there are no wires, no nothing. She has to just place it anywhere on the abdomen. IVF patients, the patients with high sugars, high blood pressure, those who require the monitoring, those who are super anxious and, complain of less movements, etc., they will do this on alternate days, send us the reports like this by the Bluetooth. We just have to give them a thumbs up and they're reassured that all is well. If it's not, then we tell them that that's the time that they have to visit us. So even this is published, and the real-time monitoring of the fetus reduces the neonatal asphyxia and the healthcare costs definitely, and allays the anxiety. There are many devices which are now available. Piramal Swasthya and Japago are on a major initiative where the femtech applications, devices integrated directly attached to the newborn's clothes, which give a lot of information on the parameters such as heart rate, temperature, sleep patterns, etc. So to implement all of these recommendations, first we have to change the mindset. It is doable, it is scalable, it can reach a lot. You will get the patients earlier on without complications so that you can do better than what you've always been doing. Patients feel reassured that you are constantly engaging them. The collaboration between the providers and the tech developers need to be strong, because we need to pitch for what we need from the technology. Lot of technology is available, but the healthcare providers have to give the guidance about what we need. Education and training for healthcare professionals, which beyond doubt the flagship program of Poxy Manyata has proven. And there are many champions right here who will endorse that. The barriers of diverse diagnostic criteria bypassed with the outline that Piki has given. Absence of self-compliance. Now you can keep on hounding her on repeated SMS messages, WhatsApp messages, alarms, etc., that she needs to be more vigilant about herself and the baby. The lack of resources and trained medical staff. Yes, we have figured our way around that. We have immense experience in training all levels of healthcare providers in their own languages in a 90-minute digital program. It is not a rocket science. They pay a lot of attention and they're hyper enthusiastic to learn and be confident and competent to do better. That is how the Manyata training across 3,500 hospitals. Now we've started individual trainings, not only on assistant to maternal newborn, breastfeeding and lactation skill assistant, the GDM course, the mental illness, and the Matra Sakhi and the Swasthya Sakhi courses for the wellness ambassadors. You will see all these in their own homes. Again, the mobile technology, helping them learn, helping them give their online exams and do the best they can in their own community. So the patient-centric telehealthcare solutions, the eSanjeevani, which is promoted by the government, but we need to be stronger in that space too. OPD, NCD care, elder care, women and child care, pre-postnatal care, home care, everything with multiple collaborations that we have through our skill academy. I think the time has come for the Femtech to move the needle forward for the better care. Last bit of the warning is that, yes, there are AI-powered solution, wearable devices, etc., but each of those equipment needs to be validated, because if it starts triggering a wrong signal at the wrong time, then you'll be totally misled. But there are very strict regulatory controls, and these instruments are not licensed unless they're validated, even in the Indian context. And so we are a bit safe on that count, but make sure that whenever you next think of using a technology-driven device, the FDA approvals, the government regulatory methodologies which ensure a foolproof validation and the use of these with a very narrow error margin is indeed the way forward. Many, many things to be done. We have exciting times ahead, and we will together ensure that the SDG Goal 3, good health and well-being for all, should be a dream come true to all of us who are championing the cause of women's health. Thank you very much for your kind attention.
Thank you, ma'am, for a very lucid and a very dynamic talk. It has certainly been an eye-opener for us. India is seeing a digital revolution in the last 10 years, and technology has now made inroads into our medical field. And with the help of technology, like the picture which you showed, that even the poorest of poor has a phone in the hand, you know, so we are, in spite of staying so far off, we are now connected. And I think this connection, technology, telemedicine can go a long way in improving the health scene in India and fighting diseases like diabetes. And the champions like you, Sneha ma'am, will achieve a lot in this field. Thank you, ma'am, for a wonderful talk. Thanks, Sneha ma'am, Dr. Monica, for making me a part of this event. Thank you, ma'am.
Thank you, Suchi, and all the best, Sneha and Vidya and all others who are marching ahead for various newer posts within our organizations. May you lead the organizations to...
Namaste, namaskar. Good evening, Hema ma'am, Bharti here. So nice to see and hear you, ma'am.
Yes. All the frontliners, our frontliners. Thank you so much.
Good evening, ma'am. It was a wonderful talk, ma'am.
Thank you. Thank you very much.
Looking forward with a lot of inspiration.
Yes. Hi, Uday.
Sneha
ma'am. Yes. So I really like the bitter truth of about your sweet, disease. Really, we need to take care of all these aspects. And whatever you have said, I fully agree with you that technology is definitely going to help us. We are watching this, people using the biosensors and even the the bands, the ribbons also they are wearing nowadays. Definitely, it's going to be cost effective. The more and more people start using, and then they're going to be very friendly. It will be user friendly as well. So I really agree with you, and I think that's a way forward. Thank you so much, madam, for your wonderful talk. Thank you so much.
Thank you, ma'am. Due to certain unavoidable conditions, Dr. Gupta sir will join for the next session, and the next talk will be by Dr. Uday Thanawala sir. Can we introduce our chairpersons for today's session, Dr. Manju Verma madam and Dr. Supriya Jaiswal ma'am. Dr. Manju Verma madam is a professor and head of the department. And she has received the Dr. Shiv Narayan Gold Medal and the BC Gold Medal.
Skip off. We would like to listen to Dr. Uday Thanawala.
Yes, ma'am. We welcome you, ma'am. Thank you. Dr. Supriya Jaiswal Madam is the chairperson of the Adolescent Committee FOXY for the current year. She is also the vice president of Patna OBGY Society, the co-trainer of the HPV project in the East Zone. We welcome you, ma'am. I request Dr. Madam to please introduce her. Can we have first slide? Yeah.
So, good evening, everyone. And I would like to thank Dr. Sneha and Dr. Monica for involving me as a part of this prestigious webinar. And to chair a session of Dr. Uday Thanewala, who has been the ICOG head person, and I have listened to him for the first time when I was in Meerut, and I was very much impressed by him. And after that, I've been listening to him to a number whenever he is giving a talk. And he is a consultant at Navi Mumbai, chairperson ICOG, vice president 2015, and treasurer PCO Society of India, chairperson medical disorders pregnancy committee, founder secretary, and past president of Navi Mumbai Obstetric Gynecological Society, and a joint secretary. And I think there are so many laurels to him, and he is not mentioning them in this. And I would not like to stay between you and the audience and the prestigious topic of ultrasound and ingredients. So, Dr. Thanewala, the mic is yours.
Thank you so much, madam. It is always a pleasure. It's a pleasure to see all friends, Dr. Hema Devakar, Dr. P.P. Saxena, Shalini was here, or she's still there somewhere. And thank you, Sneha, for calling me for this webinar. It's wonderful being here. And Supriya, congratulations and all the best to you. So what Hema just spoke about is all the technology which we are going to use to help us to monitor these patients' sugar levels, etc., etc. And it is coming in. Many people are taking it on. And my focus of my talk is on a technology which has anyway been there. We are using it in obstetrics so very frequently. In fact, we can't do without the ultrasound machine. We have to do sonographies. How is it a little different when we monitor a patient of HIT? So I would like to share my screen and let's talk about ultrasound in a pregnancy which is complicated by diabetes. So when we talk about ultrasound for fetal surveillance in a HIT pregnancy, what are we looking at? Normally, it is more or less the same. We do the sonography. It's advised in the first visit, early pregnancy, to establish the viability and confirm the dates, and which is best done between 7 weeks and 11 weeks, where you see the whole with the fetal heart rate. The 11 to 13.5 week scan is very important, which we anyway have to do. 17 to 19 week is the anomaly scan to see all the structures, including the heart, etc. Then, of course, we do a fetal echo at 22 weeks, which is more indicated in a pregnancy which has been complicated by diabetes, and we will just come to that. And of course, we follow it up with growth scans like any other pregnancy at 28 weeks or at 32 weeks or at 36 weeks. But here in a pregnancy which is complicated by GDM or diabetes, you may have to do it more frequently. So what is the risk of miscarriage is high. So even when you do your first scan at 7 weeks, be careful and look out that, first we have to confirm an intrauterine pregnancy, confirm whether it's a single or a twin pregnancy, establish the gestational age. But there are some warning signs like a slow heart rate or a decreased volume of the gestational sac, or maybe a yolk sac which is calcified, etc., which will give you, okay, maybe this pregnancy in this woman who is a diabetic may not progress as expected, but these are just warning signs which you can pick up in that early scan at 7 weeks. Then you come to the 11 to 13 week scan, and how much information can you extract from the small fetus which is there. So we basically, in this scan is the most important scan today which we do. We establish the fetal structure and we establish that whether it is normal or not. We also measure the thickness of the skin behind the neck of the fetus, which is called the nuchal translucency. And we also do the uterine artery Doppler and see what is the resistance in the uterine artery to predict preeclampsia or maybe an IUGR in future. If the uterine artery PI is more than 2.6 or 2.7, then we have to start the patient on aspirin, which is very important in these pregnancies. So basically, when you do a nuchal thickness scan, remember, we are doing it for basically rule out any congenital abnormalities. It's not only Down syndrome, it is structural abnormalities in these fetuses, because there were 3 to 4 times increased incidence of malformations compared to the general population. The frequency of congenital malformations among diabetic offspring at birth is %. The prevalence of malformation appears to increase with the degree of diabetic severity, and higher proportion of CNS, CVS, and kidney malformations have been reported. So what is the relation between the patient's HbA1c, that is the glucose control in the last 6 weeks or 3 months, to a formation of congenital malformation? If the preconceptional or the HbA1c during her first visit, when she comes at 6 to 7 weeks, is almost 6 to 6.5, that means there is no higher risk of any abnormality happening in this fetus. But if it is as high as 10, then there is a 25 to 30% risk that this fetus would have been affected and may present with structural abnormalities. So do we advise abortions? We do not, because today we have enough. Ultrasound machines give us enough information, plus tests like NIPT or a double marker test give us enough information whether this baby is normal or abnormal. We can establish that subsequently and then see if the baby has been affected or no. But all this has to be told to the patient, depending what her HbA1c is, then what is the sort of risk which she has of having a congenital defect in the fetus. So it's lucky for us today that complete anatomical surveys can be achieved in 64% of the abdominal scans and 82% of the transvaginal scan at the 11 to 13 week of gestation. And if abnormal, termination can be advised. And of course, Doppler has already elaborated what we can do. A complete cardiac evaluation is possible in 45% even at 11 weeks of gestation and 100% at 15 weeks of gestation. So today the machines are so sensitive, the radiologists are so good that we can look at the fetal heart, which can have a 3 times higher chance of abnormality as a general population. But we can have a very close look at it even at this early stage of gestation. And the same is for the neural tube defects, incidence is higher with the diabetic patient, but we can, gastric abnormalities are also there, small bowel atresia, improvement, etc., which can be picked up by the sonologist very easily in these days. Of course, in diabetics, we have obesity, which creates a problem sometimes in detection. But for that, we can use a transvaginal scan and make out how it is. Now, when you do a screening for Down syndrome and you're sending the measurement of their nuclear thickness with the biochemical markers, be careful, because you have to mention that the patient is a diabetic when you send the blood for double marker test, because the median PAPE in type 2 diabetes compared to the non-diabetic is reduced. So it results in doubling of the false positive rate. So if you don't mention it, you may get a false interpretation of the double marker. So if you're doing a double marker, please mention on the requisition form that this patient is a diabetic. Then, of course, we do an anomaly scan at 18 weeks, which gives you the intracranial structures, the spine, and again, the cardiac evaluation, which we do properly with the color Doppler, etc. And you may do a fetal echo at 22 weeks. So today, by 18 to 19 weeks, we can scan the heart very, very properly. And in generally, there is no problem. After this stage goes, the placenta allows free transfer of excess maternal glucose to the fetus, the subsequent stimulation of the fetal pancreas, and this triggers fetal hyperinsulinemia, which precipitates short-term complications in the fetus like macrosomia and neonatal hypoglycemia, and long-term consequences, that is, later on diabetes in this kid, because the pancreas gets programmed with the high hyperglucose level, which is presented in pregnancy. So now the sonography has been used to support the clinical estimation of the fetus size. Of course, you do your fundal height estimation, etc., whenever the patient comes. But 28 weeks onwards, 4 weekly or 6 weekly, we advise to do a scan to monitor the fetal growth. And you can definitely do the plotting of the graph and on the growth charts. Now, whichever growth charts you have, it is recommended that we use regional growth charts, the ones which are made for India, and there is a software which gives us these sort of charts, which is customized to the Indian women. And you can have this downloaded from the net and plot your values on the growth chart and get a result, because even FIGO recommends that local regional charts should be preferred over the universal charts, because that can lead to over detection of SGA or over detection of the growth abnormalities in the fetus. Now, abdominal circumferences is probably the most important measurement which we want to do, because it's got the best predictive value to predict a large for gestational age infant. So this parameter is found to be decreased in a small for gestational age, while increased in a large for gestational age fetus. And when you have the large for gestational age fetus, whether it is the sensitivity of either method, whether it is clinical or it is sonography, is not very high, but you have to clinically see whether actually you feel that the baby is large. And the AC was greater than when the AC was greater than the 90th percentile, macrosomia was present in approximately 78% of the neonates. So it's a good sensitive indicator if the baby is putting on more weight because of excessive glucose load. Small for gestational age babies is more difficult to deal with, because first you have to deal with the clinical side. The patient will say, you stopped all my sugar, my baby is not growing because you stopped the sugar. So we have to make her realize that it is not the sugar, it is the vasculopathy which causes this. It's a vascular disease, and that will cause the small for gestational age baby. And these babies, asymmetrical or disproportional growth retardation typically starts at the beginning of the third trimester. The sonographic estimation of fetal size in this situation is superior to clinical estimation, palpation of fundal height. So it is important to scan these people more frequently, maybe from 28 weeks onwards, maybe do a 4-weekly scan to pick up any growth disorder. Now, when you pick up a small for gestational age fetus in a diabetic, firstly, to convince them that it is not because of the withdrawing of the sugar. You need to control the sugar as it is. You need to control your sugar values, but at the same time we have to look out for any distress happening in the baby. So for that, a bi-weekly sonography and Doppler studies and uterine and umbilical vessels should be done for follow-up of SGA fetuses once it is picked up. If Doppler indicate that the fetus is beginning to decompensate, delivery should be planned regardless of fetal age. So Doppler is very, very important when you are dealing with an IUGR baby, especially in a diabetic pregnancy. So in SGA, Doppler is a good surveillance tool to judge and predict the turning point at which the fetus, the decreased perfusion will occur and the fetus will decompensate and delivery is necessary. But if you have a large for gestational age fetus with which the placenta is usually large as well, there is an increased blood flow present and the wave curve is normal, such that the usual perfusion indexes fail to pick up placental insufficiency. So for a LGA, your Doppler is not going to be very useful, but for an SGA, it is going to be useful. So unlike intrauterine growth restriction, the diabetes metabolic degeneration of the fetus may lead to acidemia without hypoxemia. So in a large for gestational age baby, the classic redistribution seen in the fetal hypoxemia due to uteroplacental insufficiency may not occur even in severely compromised fetuses. Therefore, it is important not to be misled by an apparent normal Doppler in a large for gestational age. AFI is also a very poor indicator for fetal health because AFI is generally increased with GDM, and a measuring amniotic fluid value less than 2 or even less than 5 centimeters is considered to be significantly reduced and may indicate prompt delivery. Relative hydramnios, which may occur in hyperglycemia, may for mask fetal compromise. And because of the limitations in the predictive power of most fetal monitoring methods and the lack of randomized control trials to support the fetal monitoring methods, there is no agreement on the best way to monitor fetal health in diabetic pregnancies. Now, the question is that should we give pharmacological treatment if the patient is coming to you and showing you, oh, the glucose levels are fairly okay, 90 fasting and postprandial 120. But if the abdominal circumference is more than period of gestation, so what do you do? So fetal sonography may be useful for determining early therapeutic intervention for control of maternal glycemia in GDM. And if you have fetal macrosomia or if you have hydramnios, and even if the woman is reporting normal blood sugars, it is better to step up the surveillance. Suppose you are doing only fasting and postprandial every 10 days or 15 days, put her on self-monitoring or glucose monitoring, and then you'll come to know what the sugar control is like. If that is also being done, it is probably wiser to start her on a pharmacotherapy like metformin, etc., so that we know that there is something going wrong, with macrosomia, and something is not right, and she requires more aggressive treatment. So this was the study which has been done in the standard group. Insulin was initiated if the fetal glucose, in one group they gave insulin when depending on the sugar more than 90 and 120, insulin was started. In the ultrasound group, the thresholds were 120 and 200. Means as long as the ultrasound was showing normal, even if the fasting was high and the postprandial was high, they waited and they did not start therapy. And the results of this particular small study was 38% of the patients to be managed without insulin therapy with no increase in neonatal morbidity compared with patients managed with insulin therapy based on fasting hyperglycemia alone. And they concluded that GDM management based on fetal growth combined with high glycemic criteria provides outcome equivalent to management based on strict glycemic control alone. But inclusion of fetal growth might provide the opportunity to reduce the glucose testing in low-risk pregnancies. This is one view which is there, that as long as the baby is not being affected, don't worry about the blood sugars. But what we do in practice is we go strictly by the blood sugars, but we take the ultrasound measurements of being high or the LICA being high. No, then we have to have a stricter control, and if she's not on pharmacotherapy, we have to start pharmacotherapy. If she's on metformin and you still get these values, maybe you should be thinking of self-monitoring of blood sugar 6 times a day, and then maybe even starting insulin if required. So it helps her in monitoring the growth, and if it is high, we track the fetal growth, gives us information about the intrauterine environment. And we have to, this particular study is a small study. Large studies are required that whether we can go only by sonography, but from an obstetrician's point of view and in the view of difficulties in detecting LGA, if large fetuses or thick fat layer is present, it must be assumed that the pathological mechanism of fetal hyperinsulinemia is already taking place. And the best prevention of LGA babies consists of timely identification and rigorous diet metabolic control. How accurate is the fetal weight estimation? The error of fetal estimation increases with increased birth weight and presence of maternal diabetes, so that large infants will either be underestimated or overestimated. We all know it is not a very accurate thing. Our ultrasound machine can give errors up to 300 to 400 grams, especially in late pregnancies and especially with bigger babies. So always be careful when you tell the patient baby is so big and we need to do a Caesar. Baby may still be smaller, and warn them about that. Now, the question is, fetal birth is the appropriate parameter to identify fetuses that are receiving the excessive supply of nutrients, which will result in mechanical and metabolic problems at the birth, because a large proportion of these affected newborns will have a normal weight, that is less than 4 kgs. The focus has shifted from evaluating the birth weight, then evaluating the fat layer, which is the insulin-sensitive tissue located in the subcutaneous layer of the skin of the fetuses and infants. In an LGA fetus is suspected, additional measurements should include frontal truncal skin fat layer, best obtained by the abdominal circumference measurement, skin thickness above the scapula, and the amniotic fluid index. An amniotic fluid index of more than 18 and less than 6 indicates a problem. Anything which ultrasound will tell us to prevent a stillbirth, because we know that these fetuses are prone to sudden stillbirths after 38 weeks of gestation. Well, none, because ultrasound, there is the stillbirth cause, we don't know as it is what it is. It could be relative fetal hypoxia, which increases the risk of intrauterine fetal death, or there could be placental vasculopathy, villus edema, maternal ketoacidosis, or fluctuations in the sugar level. electrolyte disturbance, and what is coming up is the fetal hypertrophic myopathy, which can be happening in these fetuses, causing sudden breast pulse. And diabetic cardiomyopathy occurs in almost 30% of the newborns of diabetic mothers. This is characterized by disproportionately thickening of the septum, resulting in transient hypertrophic subaortic stenosis with left ventricular outflow obstruction and congestive cardiac failure. Now, in general, this is a transient thing, and after birth, it generally disappears within 2 or 3 weeks. But sometimes, if this is very severe, it could be the cause of sudden ultrasound, sudden stillbirths. So basically, ultrasound is a useful surveillance tool during pregnancy complicated by diabetes. The recommendation for the use of ultrasonography is no different for women with diabetes than the general population. Between 8 to 12 weeks gestation, every pregnant should have an early sonogram for the correct gestation age. At 20 to 24 weeks, they should have a sonogram for fetal organ check. From 28 weeks onwards, it is growth estimation, especially to pick up either large for gestation age or small for gestation age babies. Small for gestation age babies, Dopplers are very, very essential. Abdominal circumference is the parameter best correlated with the nutritional status of the fetus. And bi-weekly Doppler studies and SGA is recommended. So all these points one should remember and use this particular technology which is there for managing our patients for diabetes in pregnancy. Thank you very much.
Thank you very much, sir. It was a wonderful presentation. And at the outset, first...
Oh, was the voice very low? Sorry.
Yes, sir.
Was the voice very low? Somebody was commented.
No. It was okay. We could hear.
Okay.
So
thank you very much. Somebody has commented on the box. Voice is very low, so I forgot to increase the volume.
Okay. At the outset, I would really like to thank the person behind this benchmark series, Dr. Sneha Bhuya, madam. She has made all the episodes so wonderful and so well curated. And Dr. Monica, thank you for inviting me. And I'm honored to chair the session of ICOG, past ICOG chairman, Dr. Uday Thanawala, sir. Sir, you have wonderfully explained everything. The best part was what investigations help in preventing stillbirths in a diabetic. What you said, it is none. So that was really very informative. Like we have no other way to find out. Best thing is to control the diabetes. AFI also, as you said, that relative hydramnias which may occur in HIP may mask the fetal compromise. This was also very remarkable point that you said. Then how much information can we extract from the small fetus? That's also at 11 to 13 weeks, we need to know. Then what more to look at the patient in a diabetic? That was also very nice. That risk of miscarriage, everybody knows, is higher in diabetes, and early scan really helps a lot. We have to confirm number of fetuses, establish gestational age. So the warning signs are also, and then cardiac problems early detected so well. So you have explained everything regarding the whole this topic, sir. So I think the audience must have really been benefited from your talk. And thank you so much for this excellent talk and great learning. Thank you, sir.
Thank you. Thank you very much.
Good evening, Uday sir. Bharti Maheshwari here. So nice to see, sir, your talks and my all students and my many members, they are listening. And I have learned lots from you, from the DIPSI as well as from the diabetes in pregnancy. And today's it is very specific and very clear message. So, of course, great learning. Yes.
Can I make a comment?
Yes, sure,
Dr. Uday Thanawala, can I make a comment?
Yes,
ma'am.
Yes, please go ahead.
I would like to really thank you, Dr. Uday, because you have covered everything, and it is not only that we are going to detect for the large LGA babies and not only congenital anomalies, it is the mother and the placenta all have to be monitored. So placentography is now coming up as one of the very good indices by seeing the vascularization index and the vascularization flow index, by which we can even detect the problems that can occur in the third trimester, in the late first trimester and early second trimester. So you have very rightly said that the placentography is also very, very important. And 3D I think will be even give us more information as far as the fetus is concerned.
Yeah.
Thank you. Thank you.
Thank you. Thank you so much.
Thank you, Sneha, and wish you success.
Thank you, madam. Thank you so much. Thank you for
Madam,
your
all the best, Sneha,
wonderful
madam.
talk by Uday sir. I'm very happy to see you here, sir. And as just for your information, this is the 6th episode of this The Benchmark series, and I have been covering only a focused topic, and of course the authorities in the field like you. So that is why we're very happy to listen to you today. Thank you, sir, for joining. Thank you so much.
Thank you. Thank you very much. Thank you.
Thank you, Supriya ma'am, and thank you, Manju ma'am, for chairing the session, and thank you, Uday sir, for an excellent deliberation. We now move forward for the next session by Dr. Vidya Thobi madam. Our chairpersons for the session are Dr. Manisha Ghate madam, Manoj Aglave. Dr. Manisha Ghate madam is the president of Chandrapur OBGYN Society for the current year. She is also the West Zone Coordinator for the Food, Drug, Medico-Surgical Equipment Committee, FOXI, the Chairperson of the Reproductive Tract Infection Committee, AMOX, and Secretary General of ISOPA Vidarbha Chapter. We welcome you, ma'am. Dr. Manoj Aglave sir is a consultant laparoscopic surgeon and an infertility specialist at Siddhivinayak Hospital, Bhandara. He is the Secretary of Bhandara OBGYN Society and an ex-assistant professor at the IGGMC, Nagpur. We welcome you, sir, and I request Dr. Manisha madam to please introduce Dr. Vidya Thobi ma'am.
Thank you, Dr. Monica, for such a kind introduction. Yes, at the outset, I would like to thank Dr. Sneha Bhuyar madam, Dr. Monica, Dr. Vidya ma'am for giving me this opportunity for such an academic feast. And Dr. Vidya Thobi ma'am, yes, she really doesn't need any academician at par. Madam has been the president of KASOGA in 2023. She has also been the chairperson of FOXI Food Drug Committee from 18 to 20. And Best Committee FOXI Award she has bagged in 2020 also. And she has also bagged many awards like FOXI Champion, National. She has been also a member of ISOG Governing Council and organizing chairperson of KASOGA 2016. She has many publications in various books and has contributed as faculty speaker at national and international conferences. With this, I finish my introduction of Dr. Vidya Thobi madam. Madam, the floor is all yours. Please proceed.
Hello, Sneha.
Yes, I am ready.
Yes, can you share my
Yes.
share my presentation?
Can you see?
I
Yes,
can
ma'am.
see and make it full screen
Yeah,
if
it
possible.
is full screen. It is full screen.
So,
Go
thank you for inviting me to this very important webinar, where I am touching upon the nutrition and medical nutrition therapy in hyperglycemia and pregnancy. So, as we all of us know that nutrition is a cornerstone of any treatment of hyperglycemia in pregnancy. And hyperglycemia in pregnancy is increasing steadily. 1 in 6 live births occur in 2 women with some form of hyperglycemia, and 84% are due to gestational diabetes. So even we get the borderline cases also. They may turn out to be, if the nutritional interference, we can definitely manage these cases. So we know the impact of gestational diabetes on maternal and child health, short-term impact as well as long-term impact, and the cost of inaction. We all know that it is a future of non-communicable diseases, and we know the intergenerational transmission of these diseases, and we know that a child up to 8 times is more likely to develop type 2 diabetes in mother if mother has had GDM. Okay, so what is the goal, strategic approach, and activities to improve the maternal and fetal outcome by the universal testing of pregnant women for early diagnosis and management of GDM through its integration in essential continuum of care package, that is antepartum care, intrapartum and postpartum. And this strategic approach is to, again, the diagnosis, that is screening in early pregnancy as well as in mid-trimester, as well as in the third trimester, and the postpartum follow-up, which is also very important. And the key objective is to generate, main important is a community awareness, early diagnosis and management, and establishing linkage with non-communicable diseases and program in accordance with the national guidelines. And I'm very glad that there are national guidelines as well as FOXI guidelines for the screening as well as management of gestational diabetes mellitus. My earlier speaker have touched upon the various aspects of the management of hyperglycemia in pregnancy. Next slide, please. Yeah. So management of GDM, general management, medical nutrition therapy, the exercise, also lifestyle modification is very, very important. And then second part comes is a medical therapy, which contains that oral hypoglycemic agent and as well as insulin therapy. So we are touching upon now the medical nutrition therapy. Next slide, please. So medical nutrition therapy in GDM primarily involves a plan which promotes the optimal nutrition for the maternal and fetal health. And second one is adequate energy for appropriate gestational weight gain. That is also very important, and the achievement and the maintenance of normoglycemia. And the main important thing is definitely we have to avoid the ketosis and minimize the insulin. Already if the patient is on insulin, we can minimize the insulin requirement. So always in all parts, even if the patient is on oral hypoglycemic agent or insulin therapy, the medical nutrition therapy is the main treatment which we are going to advise to all the patients. Next slide, please.
Yes.
Yes. So medical nutrition therapy, the importance of dietary management of in GDM and the principles of medical nutrition therapy, how to start with MNT, caloric requirements and distribution, and carbohydrate counting, glycemic index, and sources of macronutrients like proteins and fats. Not only carbohydrates, we have to think the whole diet. We have to plan the meal pattern and the portion size. All the three things are very, very important things in the management of hyperglycemia in pregnancy. Yes, next slide, please. Okay. So we are talking about the practical approach, and whenever we are talking about practical approach, we have to make the patient understand why the diet is very important in GDM. So one thing we should tell her that pregnancy hormones, which also is again, there is a which build up the glucose, and second thing is whatever she is eating from food, that glucose also comes from the food. Then again, sometimes she may need insulin to break down this glucose, and more glucose is also, there is a neoglucogenesis from the liver. There is again stress. Stress also increases the adrenaline and the glucagon. So these are the factors why we also tell that pregnancy is a diabetogenic, and also the diet is very important in GDM. Next slide, please. Yes, the counseling should be we have to tell particularly about the implications of GDM on her, for her baby and herself. The dietary and exercise recommendation, regular monitoring is, even the patient is on MIT, she has to monitor the blood glucose, and if required, administration of insulin and adjustment of insulin dosages. identification and treatment of hypoglycemia. Sometimes the patient is on insulin, and then if she eats less, also we have to tell her what are the signs and symptoms of hypoglycemia, and then she has to adjust her insulin dosages. Identification and treatment of hypoglycemia is very important in these patients. And care to reduce stress, cope up with the denial and anxiety. Always the patient will be anxious how she can manage only with MNT. So next slide please, Sneha. Yes. So nutritional interventions are very, very important. And as I told about the minimizing the insulin requirement, which also lowers the serious perinatal complication among the infants. It lowers the perinatal mortality, lowers the percentage of large for gestational age, and less macrosomia, of course. So these are very important things when we are talking about medical nutrition therapy. Next slide, please. Next slide, please. Why diet is important? Previous slide. So why diet is important in managing GDM? It helps in managing blood sugar one thing. Second is it provides all the nutrients required for the mother and fetus. And third is it helps in managing appropriate weight gain. Next slide, please. And how to start the medical nutrition therapy? One is take the anthropometry of every patient, height, weight, and BMI. Based on BMI, categorized into obese woman, more than 24 kg per meter square, non-obese, less than 24 kg per meter square. Calculate the ideal whatever the BMI is required by seeing her weight, height, minus 100. We have to calculate this ideal body weight. Then calculate the calories required for obese woman. And most important is the calculation of the energy requirement by basal metabolic rate into the physical activity level. Basal metabolic rate for an adult female is already calculated by 18 to 30 years, 14 into body weight, plus 471, basal 3 into body weight plus 788, pre-pregnancy body to be taken into consideration when calculating the requirement. So that's how we have to first calculate how much energy she really requires. Next slide, please. Yes, so this is just an example how they are calculating the BMI and how they are multiplying, they are calculating the basal metabolic rate and identifying the physical activity level. So you have to calculate first how much kilocalories she is requiring, and then you have to spread out these kilocalories throughout the day by various means carbohydrates, fats, and proteins. Next slide, please. Next slide. Yes. So we have calculated these kilocalories, and 30 kilocalories per kg current weight per day in pregnant woman whose BMI again is between 22 to 25. So we require the less kilocalories if we have to provide in morbidly obese pregnant woman. So BMI calculation is very, very important in each and every patient comes in your clinic. Next slide, please. Next slide, please. Yeah. So medical nutrition therapy, the calorie distribution according to the American Diabetic Association, which recommends the composition of diet for a woman with GDM is around 25% of the fats, 25% proteins, and 50% of carbohydrates. Next slide, please. Yes. So this is a carbohydrate controlled diet mainly, and carbohydrates are really required for the fetal brain development and the functioning. So minimum 165 grams of carbohydrates per day, 40 to 45% of the total calories. So this is again distributed in 3 meals and 3 to 4 snacks and 2 to 3 hours apart. And low GI foods can reduce postprandial glucose levels. That is very important. So we have to know about the glycemic index of what carbohydrates we are eating. Protein should be taken with meals and snacks, and wide inter-individual variability for the time of the day. So you should always avoid the over restriction again. This whenever we are talking about medical nutrition therapy, food changes into the blood glucose. This you should remember. If you eat carbohydrates up to 100 glucose, and proteins take 3 to 5 hours, and fats less than 10%. So their conversion for the fats to the blood glucose is really less. Next slide, please. Hello?
Vidya, it's already there.
Next slide, please. Yes. So this is about the glycemic index, as I was talking. Yeah. So I was talking about glycemic index, which is a figure which is representing the relative ability of carbohydrate food to increase the level of glucose in the blood. So low GI is less than 55% is converted to medium GI and high GI. So you should remember what are the low GI foods. And this is just remember, this is a my GTM plate. I must congratulate Hema Divakar madam. So she brought this GTM plate, and this is very easy. In your clinic, you can explain to the patient that how much proteins, how many vegetables, how much starch, and you should put in the plate and eat. So this plate method is very, very useful. And what I feel is you also remember this hand. So handful of carbohydrates, palm full of meats, that is proteins, and fist at least veggies, rice, and pastas, and fingertip is fats. This, if you remember this GTM plate, it is very easy to explain to the patient how much he should eat. Next slide, please. Yeah. Yeah. So what is the signal system? This also, what are these colors? This red means high, that is food is high in fat, sugars, or salt. Amber is medium, which is okay choice, and the green is low, means it is a healthier choice. So one concept, and there are many names. So this is a signal system. Next slide, please. Yeah. So this, if you think this like white milled rice, sona musuri, whatever we are eating, no, these are refined grains. We should avoid these refined grains in diabetic patient. We have to replace with healthy grains like barley, brown rice, quinoa, or millet flour, or bajra, or anything. So we have to replace this by this one. And this is all. Next slide. So this is a nice representation of the healthy and unhealthy food choices, like steamed brown rice to the white rice and biryani. So you have to always choose the steamed brown rice, whole grain bread, or grilled fish, or green salad and fresh fruit. So you remember this green and the signal system, and tell to your patients. Next slide, please. Yeah. So complex carbohydrates with lower glycemic index should be preferred, and many carbohydrates there are varieties of carbohydrates which you can offer, and you can plan the meals by balancing these carbohydrates. For every meals, you can tell the patient it maintains the glucose levels with the target range. And we can also check which are eaten at each meal by recording the carbohydrates, how many grams she is eating, and what are the choices of carbohydrates. So 15 grams of carbohydrates is equal to carbohydrate choice, so one carbohydrate choice. So 30 grams of carbohydrate, 2 choices, and 45 grams of carbohydrates, 3 choices. So carbohydrate exchange and carbohydrate counting should be taught to the patient. Next slide, please. Yes. So counting of this one, and food exchange list you should tell. So patient can manage the portion size, the consumption of carbohydrate reduces, easy to make a meal plan, and gets to eat variety of foods. So 11 to 12 exchanges in a day would help to achieve the carbohydrate target of 175 grams per day. So this can be taught to them that, and also this whatever she can exchange with various varieties of food, so that there is no monotonicity, or she can eat little bit sweets also, and she can manage her blood sugar levels. Yes. Next slide, please. Proteins are very important, as we know, and 23 grams additional proteins are required. So at least 3 servings of proteins are to be given. Next slide, please. Yeah. And fats also, we should remember that saturated fat intake like ghee, butter, coconut oil should be less than ideally 10% of the calories. So good fats like omega-3 fatty acids should be always taken from the nuts and seeds, and the fats can be reduced from the diet. using less fats in cooking, avoid the frying foods, all those advices you can give to the patient, and you have to spend enough time in counseling and prescription of the diet for these diabetic patients. Next slide, please. And choose from the healthy fats. That's what we tell. Like you can just put all the one by one, Sneha, so that I can just present them about the healthy diet. Yeah. So this one, polyunsaturated fatty acids and monounsaturated fatty acids are good, and the very trans fats are very bad. So these are the various oils which you can prefer in your patient, like olive oil, canola oil, nuts and nut oil, seed oil. Like sesame oil is very good, walnut oil and fatty fish. These are the very good healthy fats for the diabetic patients. Next slide, please. So another important thing is the fiber in the diet. So especially soluble fiber is also equally good for the control of good blood sugar by delaying the gastric emptying. All fruits and non-starchy vegetables like nuts and seeds like fenugreek seeds, like methi seeds, you can soak these methi seeds and give next day you can eat them, and even the flax seeds. These are very good dietary fibers you can advise to the patients. Next slide, please. Yeah, this is just in overweight and obesity patients who come to a clinic, and this is very good chart which we in our government of India they have printed, and what is do's and don'ts, food which can be included, like mid snacks. They have nicely printed, and you can just print this and put it at your clinic, and it is very attractive, and what should be taken and what should not be taken by diabetic patient and obese patient. This is very important. Green leafy vegetables, bajra is good, and now they prefer millet dosas. Millet, and that has got really less glycemic index, so that can be preferred by these obese women. Next slide, please. Yeah, so this is what I told about the do's and don'ts, and they advise about the small meals throughout the day, plenty of the green vegetables, less, they have to take tea, and coffee should be avoided actually, and without sugar. And hydration in these patients is very, very important. And that's what we have to imbibe on them, that little bit at least they have to walk, do sitting also at home will definitely increase their blood sugar level. So they have to do some lifestyle modification, and they have to check their regularly. They should check their blood pressure and like this blood sugars as well. The meal plan and pattern in the second trimester and third trimester, 3 meals and 3 snacks. In third trimester, they say that you have to take 8 small meals. So morning snacks followed by breakfast, mid-morning, lunch, evening snack, dinner, and mid. So these, the meal and meal pattern, they have to divide like this in the second and third trimester. Next slide, please. And most important is the monitoring of the blood sugar. Not that MNT is given and we have to just, we should stop, but you have to just take, and you should know the target sugar level. Like before breakfast, 69 to 90, before lunch and dinner, 60 to 105. After meals, less than 120, 2 a.m. to 6 a.m. Sometimes you can check off. It is not often you should check, but first, after MNT, you should have these are the target levels which are aimed at. So, and the target weight gain also. And another thing is this target weight gain is, I just wanted to tell, the normal weight gain, what we expect is 11.2 to 16 kg. When the patient has got like underweight patients, that 12.5 to 18 kg, overweight 7 to 11.5 kg, and very obese around 5 to 9 kg weight gain we aim at. Next slide, please, Neha. Yeah. So till when you should continue this only on MNT? It may not work in some of the patients. If 3 consecutive readings are more than the target blood glucose level, fasting more than 90, or PPBS more than 120, reconsult, find out what is the reason, whether she is following your advice or she requires some oral hypoglycemic agents or insulin. You have to find out, and then this one. And if the patient is already on insulin therapy, you are giving MNT, you them to take small frequent doses of insulin and keep sugar candy or banana handy if she experiences hypoglycemia. And monitoring of sugar level is very, very important in these patients. Yes. Next slide, please. Yeah. So I was talking about the lifestyle style management. Also, FIGO also endorsed about the lifestyle management and about the nutritional counseling, physical activity. These are the primary tools in the management of GDM. And also practical nutritional education. And there are nutritional educators also. Everybody cannot afford to have a nutritionist in that, but at least we should know how to counsel and tell them what to eat, what not to eat. So this is very much important, and that they should be repeatedly advised. So to continue in further also. So we know about.
Hello. I think we have lost Dr. Vidya's connection. I hope she joins back. By the time I will just talk about this slide, that this FIGO recognizes that nutrition counseling and physical activity, these are mainly the primary tools in the management of gestational diabetes. And FIGO recommends that women with GDM should receive the practical nutrition education. It's not that how many calories you should have, your BMI is this, your weight is this much, and what is the level of sedentary activity. She will not understand. On top of that, you have to calculate the exact calorie requirement. So calculate the exact calorie requirement, advise her regarding her exact spread of calories, how should be her spread, what all foods she should prefer, and what all foods she should avoid. So women with GDM must be repeatedly advised to continue the same healthy lifestyle. So not only the diet, but also the active physical exercise. And the advice at active physical activity is almost 30 minutes per day. So moderate physical activity of 30 minutes per day, that is 5 days a week, that is 150 minutes per week. That is what is described. Now this is only, again, the FIGO recognizes that the nutrition counseling and physical activity, these are the primary tools in the management of GDM, and these women should receive the practical education. Now, these are the kind of charts which actually they are available. They're made available by Government of India. They are displayed at the PHCs and CHCs. So all of you can see here the food pyramid also, and what kind of exercises they should do. Everything right from the beginning, if you read it here, what is the effect on the mother, effect on the baby, how do you identify, that is the universal screening test with single step OGTT, and if at all you diagnose them with GDM, what should be the initial therapy? That is how it is given. So do we have Dr. Vidya in the network?
No, ma'am, not yet.
No, not yet. Okay. So this is a article from this Curd journal, and this is by Christina Castilla. It is published online on 15 February 2016, and it gives you the role of medical nutrition therapy in the management of gestational diabetes mellitus. So that means every evidence supports the role of medical nutrition therapy is very, very vital in the management of gestational diabetes mellitus. So this is a GDM card, what I was talking about. This is also available along with the informative booklet. This is also available as a card, and you have to fill the information in this card. So controlling blood glucose.
As Neha, I joined back. I had some network
Very good,
issues.
very good.
Yeah.
We are eager to listen to you. Continue. So GDM
you were talking, I was talking about the general counseling, and the GDM card is very important, and this has been a part of my always a discussion whenever I talk with the deep clinics or you advise is, it is general advice, and controlling blood glucose is very critical for the mothers and babies' health. This has to be imbibed on whole family, because many times we all know that they are called for any baby shower or something, and there they go eating some sweets. One time advice, and there is always uncontrolled high glucose complication. So this is a simple chart they can put, and here they can just modify their diet chart. Second thing I just wanted to tell about the FIGO nutrition checklist is very important. It was created in 2015, and of course the purpose is again to collect the basic information of the nutrition, personalized conversation with the woman. And second thing I just want to tell our Indian various food groups. So next slide please, Sneha. There are various food groups I have just shown. So this can be very nicely implemented in our country as well. Yes. So FIGO nutrition list specifically ask about the 6 food groups, and this is just the next one is what has been achieved by us. So even we can train these ANMs. We have to take the nutrition assessment, their height, weight, their mid-arm circumference, their hemoglobin checkup, and then we have to advise about, we have to classify about the nutritional risk, whether she's short, whether she's young, low BMI, very low mid-arm circumference, whether she's obese, and then inappropriate weight gain, whether she's having, sometimes their woman feels that if she's having GDM or she's obese, she has to eat very less, and that also leads to complication. Then anemia, her blood pressure should be checked. And then after classification of these nutritional risks, you have to spend enough time about the individual counseling and treat moderate anemia by giving iron tablets and advise her about the nutrition. So it is very important. Group counseling is also important. Family counseling is also important. So this is a part of our training program, that how to counsel a pregnant woman and how she should continue the diet control and physical exercise. So this is very, very important part of my talk actually. Yes, and this has been given in Government of India's booklet, and this is a simple what you should tell to the patient, like 1800 calories sample meal plan for GDM. So how much she should eat at the breakfast, then mid-morning, then lunch, evening, dinner. So it is a 1800 calories sample plan. You can give this chart, and whatever she is having availability at her home, accordingly we should modify her chart. Of course, the vegetables and all those things, proteins, whatever she is having at home, that can be modified and it can be given. The seasonal fruit should be advised, whatever is available at that place. And murmura chart or whatever vegetable which has got very low calories, and even chapatis, whatever they are eating, that can be put some multigrain and make them less glycemic. So there are various charts like 1800 kilocalories and 2200, 2500. These are very interesting charts, and even South Indian, East India, West, as well as North, all types of charts are available at the website. So next slide, please. Yeah. So Dr. Hema Divakar madam had told about various innovations, and sometimes we have to monitor various gadgets are there, like insertion of such biosensor through subcutaneous route, and that will show you the graph, how much she is really controlling her blood glucose levels. And also there are various apps have come up, where she can use those apps, how much calories she has eaten and what can be done. So these are very useful whenever we are monitoring her nutrition. Next slide, please. And this is just a book which is available at the website, as well as you can download. And in that book, the simple chart is given how we can manage a pregnant woman with GDM. First, always the medical nutrition therapy, follow for see her with the medical nutrition therapy, just shift to the insulin or oral hypoglycemic agents. So thank you very much. These are references. I'm really sorry I had to travel gently, so I could not miss, but somehow I could complete Sneha the topic and the talk. I feel so. In between, for any queries, definitely I'm available, and my mobile number I can put when I'm traveling to answer various queries. Thank you very much. Thank you, Sneha. You have brought in very important topics and very interesting topics.
Again.
Very practical topics for the various medical disorders in pregnancy. Thank you very much. Thank you.
Over to you, Manisha ma'am and Manoj sir, for your concluding remarks.
Hello.
Yes.
Madam
Yes,
rightly
sir.
said that the nutritional therapy is the cornerstone of the management of diabetes. And she has rightly explained the role of anthropometry in calculation of the calories. And also she rightly explained the meal schedule for the pregnant woman. And that the lifestyle modification is also very important in the management of diabetes before starting the medication. So excellent presentation as usual. Thank you for inviting me for chairing this session. And all the best, Sneha Buhar, madam, for your upcoming elections.
Thank you so much, Manoj, for in fact accepting the invitation at the last moment. This was a program which was made little hurriedly because we were also waiting for the faculties to confirm. And of course, Madam Shalini Jackie, I must appreciate your punctuality and presence till the end. We are very happy to have you as chief guest today. Dr. Manisha Ghate, the president of Chandrapur Obsgynae Society, we are very thankful to you for accepting the invitation. All of you know that I am contesting for vice president proxy, and as I have already said that even though it is not pleasant for me to request for you all the time for votes, yeah, just for a moment I have to say that please do support me for my upcoming elections. And thank you so much for all your blessings. Thank you so much.
Best of luck, ma'am.
All the best,
Best
ma'am.
of luck.
All
Yes,
the
ma'am.
best, madam.
Best of luck.
All the best.
Thank you so much. Thank you, Dr. Moshmi. I hope you have nominated me from Bengal Obsgynae Society. And
Yes, ma'am.
yeah, thank you. And I'll be coming soon to Kolkata on this 21st,
Yes.
2nd June. So I'm invited as a faculty in the Wisdom Conference. Thank you so much. I think without much ado, we should go ahead with the next Dr. Monica. And Dr. Sunil Gupta is already here. In spite of his hectic schedule, just at our request, he has joined. So welcome, Dr. Sunil Gupta. Yeah, over to you, Chairperson.
Thank you, Manisha ma'am and Manoj sir, for sharing this session. And thank you, Vidya ma'am, for an elaborate talk on importance of nutrition in prevention of gestational diabetes mellitus. We now move forward for the next session, that is empowering the OBGYNs for therapeutic management of the gestational diabetes, which will be spoken by Dr. Sunil Gupta sir. Our chairpersons for today's session are Dr. Bharti Maheshwari madam. She is a professor and the head of the department of the Muzaffarnagar Medical College. She also holds a diploma in IVF and reproductive medicine from Germany. She was the chairperson of the FOXY MTP committee for the year 1820. She is a member of the governing council ICOG. She has been the secretary of UPCOG and the president of the Meerut OBGYN Society. We welcome you, ma'am. Our next chairperson, Dr. Deepika Devani, madam, is an associate professor at the Varda Medical College. She is currently the president of the Deoli Sanghi OBGYN Society, and she has many fellowships to her credit. We welcome you, ma'am. I request Bharti madam to please introduce Dr. Sunil Gupta sir.
Do we have Dr. Bharti? Otherwise, Dr. Deepika can do the honor.
Yes.
Yes, ma'am. Ma'am, at the outset, I would like to thank you and your team for having me for such a valuable and important session. I consider it my proud privilege to introduce Dr. Sunil Gupta, sir, an eminent endocrinologist from Nagpur. He is consultant diabetologist and has done his UG and PG from IGMC Nagpur. He has won six consecutive Best National Research Paper Awards from Research Society for Study of Diabetes in India, has presented multiple papers and published multiple articles, books, as well as abstracts in national and international journals. His name has been included in prestigious Guinness Book of World Record for participating in the largest diabetic health screening at multiple locations. He has been honored with Fellowship of American College of Physicians, Royal College of Physicians, Glasgow, and has been honored with 5 national fellowships, 3 presidential orations, 9 national orations, Professor Sam G.P. Moses National Oration. In 2016, he has been Joint Secretary of DIPSI Asia from 2015 to 16, and he is the National Joint Secretary of DIPSI from 2006 to 2015.
Madam, we can stop here. I can be, for the want of time, we should be now focusing on the with the permission of the chair. Can I start the session?
Sure, sir. Sure, sir.
Now, before I start, can I ask? Thank you very much, Sneha ma'am and Deepika ma'am and everyone who has been in touch with me since last few days. And unfortunately, today it was too hectic for me, and I could not really focus on the remaining meeting, what has been already discussed in earlier lectures. So there could be little repetition. What I suggest is, Sneha ma'am, as well as thank you very much, Monica madam, for calling me every time and getting it coordinated from Solapur. So my humble congratulations and thanks and all the best to Sneha ma'am for her election in very near future. My suggestion to the chairperson, and this is, do you want me to deliver a lecture or do you want to have a simple question answer session which chairperson can ask if they're already prepared, or those who have something in their mind? Because interactive question answer session will be a good way of engaging the delegates rather than a monotonous lecture, which I already have got it with me. But if you can just change the format, if it is possible. Sneha ma'am, I can have your...
Yeah, definitely.
So maybe we can I'll just speak for 5 minutes without the slides about HIP, hyperglycemia and pregnancy. Meanwhile, I request chairperson to prepare some questions. You can ask me. If possible, I'll try to give the answer in the best possible manner. If something which I don't know, I'll say I don't know that, and that is what a medical professional's limitations sometimes have. But nevertheless, that becomes a better way of explaining rather than this is what I at this moment of time, especially when we are already possibly late for the evening.
In fact, I agree with you, because that is how every program which I moderate I moderate it as a panel discussion. Yes. So case-based discussion. So, but this program has a different format because we want to have the in-depth knowledge of that particular subject, and that is why the format is like this. But doesn't matter, we'll be very happy.
I have got slides ready with me. If you want, I can certainly speak on that for next 15-20 minutes or 10 minutes, whatever is assigned to me, if possible. Yes. How much time I have, by the way?
Yeah, 15 minutes.
15 minutes. So if you want, I can speak, or if you want, we can just have a question. I'll speak for some time, 5 minutes, and then
I think please, you can start your talk so that the chairperson also gets stimulated, right, Deepika? You can have a few queries also for sir.
Yes, ma'am, definitely, ma'am.
Please.
So, should I show the slides or we go ahead like extempo?
Extempo is also okay. In fact, you initiate the discussion. I think that should be good.
Yeah. So, thank you once again and congratulations for everything and all the best for ma'am. Now, HIP, hyperglycemia and pregnancy is certainly a challenge for every one of us. And we should know that every 4th woman in Southeast Asia, I repeat, every 4th woman in Southeast Asia, including India might be having 5th, or sometimes 6th. But every 4th woman in Southeast Asia might have some kind of hyperglycemia in pregnancy. 85% of them are going to be GDM, which possibly appear in pregnancy and disappear after the delivery. But remaining 15% could be pre-existing type 1 diabetes, type 2 diabetes, undiagnosed diabetes, and then have suddenly diagnosed during the screening program and during the pregnancy. Important is the age of childbearing, the pregnancy is increased. The age of pregnancy is increasing, age of diabetes is reducing, and there's a mismatch. So now we are getting more and more number of pre-existing young women who are never diagnosed, never tested their blood glucose earlier, and have suddenly come with the pregnancy with hyperglycemia, and it could be with HbA1c of sometimes 8, 9, 10, and 11. So because almost 141 million people we have who are pre-diabetics. 100 million people, we have diabetes. And we know that pre-diabetes in non-pregnant state is diabetes in pregnancy. I repeat, pre-diabetes in non-pregnant women is GDM in pregnancy. The cutoff is 140. Here also cutoff is 140. So we have big number of 140 million adults above 18 years of age who are pre-diabetics. 100 million diabetics. So if we just add them, it comes to almost 125, almost 25 crores, 14 plus 10, almost 25 crores. That means every 4th adult person might be having either pre-diabetes or diabetes, and almost 50% of them are women, so above 18 years. So we are going to face many women with GDM more often, and this has been proved in the Lancet study. Now, if we get a woman who has been diagnosed in these 24 weeks, 24 to 28 weeks, we call it as a pure gestational diabetes, which is likely to disappear after pregnancy. And most of the GDM women, I repeat, most of the true GDM women will present to you with postprandial hyperglycemia. That means fasting will remain normal. Fasting will be in 70s, 75, 80s, sometimes never crosses 90 in GDM women. And postprandial will be maybe 140, 150, 160, 170. And these women who have postprandial hyperglycemia, with this postprandial spike is not good for the baby. So if it is a pure GDM, fasting will remain normal, and postprandial hyperglycemia will need to be controlled. 70% will do well with the previous lecture of medical nutrition therapy, that they will do well on without any pharmacotherapy, but 20 to 30% may need pharmacotherapy, which is possibly today's talk here. So these women who are gestational diabetes, I'm not talking about pre-gestational at this moment of time, they might need 30% of them may need either metformin or the insulin therapy. There are 2 other drugs, that is clebenclamide and acarbose, which have been approved. But in India, we are using at this moment of time, Government of India has approved metformin, and DIPSI also says that metformin can be given if there is no contraindication. Metformin, you can start with maybe 500 milligram twice a day, and you can build up the dose up to 2 grams per day. But 50% of the women, please remember, 50% of these women who are pure true GDM will not respond well to metformin therapy alone, and they might need additional pharmacotherapy, that is insulin therapy, to achieve your target of fasting as 90 and postprandial 2 hours is 120. Postprandial, when we say, it should be post-breakfast, post-lunch, as well as post-dinner. Unfortunately, our clinicians, they don't monitor post-dinner blood glucose. Many of them, they monitor post-breakfast. Few of them will monitor post-lunch. And we always forget to monitor the post-dinner blood glucose. In our own study, which we have done from Central India, on type 2 diabetes pre-gestational as well as gestational, we have found that the breakfast dose is minimum, lunch dose of insulin is little higher, and pre-dinner dose is highest. That means our population in this part of the country, especially Central India, including Maharashtra and some part of Madhya Pradesh and Chhattisgarh, have very high calorie intake at the dinner time and less in the breakfast and lunch time. Possibly that is the reason why they are requiring higher dose of insulin at the dinner time versus breakfast and the lunch time. So whenever you stick at a case of just pure gestational diabetes, certainly you should try a medical nutrition therapy for 2 weeks. Try to fix up your targets at 90, 120. If you don't achieve it, start with maybe metformin if it is not contraindicated. And if don't achieve well blood glucose control within maybe 10 to 15 days, you can certainly start insulin. Monitoring is the only blood glucose monitoring at home is the only simple, important measure with which your pregnancy outcome is attached with. More you monitor, more you control, more better is going to be neonatal outcome. That is what happens in GDM. If metformin failed to achieve it, then you can certainly, being a postprandial hyperglycemia, such people will require short-acting insulin at breakfast, lunch, and dinner. It is highly individualized, and then according to the patient, you can certainly adjust the doses. Most of these women might need around 0.4 to 0.5 unit per kg body weight of their pre-pregnancy weight, which will increase as the pregnancy advances. As the pregnancy advances, there is increase in the insulin resistance, increase in the placental hormone from the HPL and other hormones, and these hormones will increase the insulin resistance, and the insulin requirement goes up to almost 1.5 times till delivery. And once at around 37 weeks onwards, then the insulin requirement suddenly starts getting stabilized. And by 37, 38 weeks, when you get delivered, most of the time, these patients may not require any insulin. After delivery, few of these women may remain diabetic. 10 to 15% may remain diabetic, and rest of them will become normal, and they may not need any glucose lowering therapy. Now, this is what is most important when it comes to GDM. Now, the second part of it, those who are delivered and then the blood glucose is normal, these women should be further observed for 6th day, 6 week, and 6 month, and then once in a year they should be tested for blood glucose and see whether they are developing diabetes. And once in a year they should keep on checking their blood glucose. And then those who remain diabetic till they breastfeed the baby, insulin remains the drug of choice during breastfeeding. Most of the oral drugs, they are being excreted in the milk, and metformin as well as glipizide, these are two drugs which has been excreted, but it is in the minimal amount and can be given, but insulin remains the drug of choice even during lactation if the mother remains hyperglycemic after delivery. Now let me come to the pre-gestational diabetes, because you and me are seeing more and more number of undiagnosed. Even today, just half an hour back, I got another patient at around 14 weeks of pregnancy with HbA1c of 11.5. Now, 14 weeks of pregnancy, 11.5 HbA1c. Gynecologist says what to do. I said what to do. Better we put it to the family. I told them that there are almost 20 to 25% of the chances that such babies might get the problem. Earlier, she already had one history of stillbirth in the previous pregnancy. And now this lady again came with high blood glucose of 11.25. Someone put them on pre-mixed insulin twice a day. Again, I tell you, when it is a pre-existing diabetes, either type 1 or type 2, they should be compulsorily put on basal bolus therapy. So they should be put on short-acting or rapid-acting analog at breakfast, lunch, and dinner, and a long-acting insulin at bedtime, which are approved insulin, regular insulin, human insulin, NPH insulin, aspart insulin, lispro insulin. They have been approved. Degludec and glargine can be given if the patient is already on the drug, and if clinician feel that by withdrawing this drug, the mother may land up into hyperglycemia. So in such cases, those are already taking it can be continued, but drug of choice remains as aspart, lispro, and levemir, and regular insulin and NPH insulin. So now we have to switch over to basal bolus therapy in this lady, and then we'll try to achieve 90-120 mark as early as possible. And we have explained them that the big chance of around 20-25% to the neonatal outcome. If you want to continue this pregnancy, which seems to be a precious pregnancy for them because the first baby they already lost, they may continue it, but then you have to control blood glucose very, very aggressively and take this 75% remaining chance that everything is going to be normal here onwards. She also has proteinuria, which again becomes a risk factor for preeclampsia, and this could be should be again looked into, and we have to also see retina in such patients. So preconception counseling in those women who are known type 1 or type 2 diabetes is most important. We should try to achieve fasting less than 90, postprandial 2 hour less than 120, HbA1c try to achieve less than 6 before they get conceived. And this preconception counseling is most important, especially when the women comes to you for infertility who are known type 1 or type 2 diabetes, and they should always try to involve a physician, get their retina checkup done, get their kidney checkup done, get their heart evaluation done. So cardiovascular, renal, and the retina evaluation is must in such patients if they have associated complication. So few of the women who have proliferative diabetic retinopathy, autonomic gastroparesis, those who have coronary artery disease and problem with the ejection fraction or cardiomyopathy, or those who have renal impairment, this is the contraindication for pregnancy. But other women, most of the women will be fit for it. So they should get a fitness. I repeat, every known type 1 or type 2 pre-existing diabetes, whenever planning pregnancy, should always be put on insulin therapy. Stop all contraindicated medications like statins, ACE inhibitors for blood pressure, ARBs, all safe medications, metformin, other anti-diabetics should be stopped if it is type 2 diabetes, and should achieve HbA1c of 6, if not at least 6.5. If there is a high risk of hypoglycemia in type 1 diabetes, up to 7. If you achieve this, then you can say, yes, retina is normal, no renal nephropathy, your cardiovascular system is normal, blood pressure is normal, you're on safe drugs, you have achieved blood glucose control, what is expected. Now you are fit for pregnancy. So now you should ask all these women to get a fitness for conception if they are known type 1 or type 2 diabetes. So we have discussed about the preconception counseling. We have discussed about the diagnostic criteria, must have already been discussed earlier. MNT has been discussed. Pharmacotherapy, I told you about metformin, I told you about insulin, and the doses has to be highly individualized. Now, if you have some other things to discuss, certainly there are some controversies about metformin, about PCOs, all these things. I'm just stimulating you to ask me the questions, and then we can wind up. I feel, madam, I have taken almost 7 to 8 minutes for briefing you about GDM, which is in the best possible manner. But certainly you must have prepared few questions for your own fraternity. What is more required, I will come to know more from your end. Yeah.
Sir, I will ask you the very basic question, what every obstetrician thinks, the women with PCOS, they are on metformin for their treatment before conception. And once they conceive, they continue with it. Okay, so when they conceive it, we allow them to continue. Okay. But then otherwise, we say that metformin should be used after 20 weeks of pregnancy. So how do you take this? How do you explain this?
For all, there are two things. One is GDM, one is PCO. Polycystic ovarian disease, main purpose is fertility. Once the woman gets conceived, once pregnancy sets in, then there are enough papers available across the globe, and there's a good meta-analysis that metformin can be continued up to 12 weeks of pregnancy. After 12 weeks of pregnancy, there is no additional benefit of continuing metformin in pregnancy. After 12 weeks, you can withdraw metformin and there is no additional benefit of neither for prevention of GDM nor for prevention of preeclampsia. So there is no there is no reason why should we continue metformin in such women who had PCO. There are very clear guidelines. One is polycystic ovarian disease.
Yeah.
Now, the European Association last year, 2022 February, has come out with a data on the basis of a data which was MITI trial. MITI trial is those women who already pre-existing type 2 diabetes, they started them on metformin pre-conception, continued it till delivery, and they found there is no much difference as far as the neonatal outcome is concerned. There is no teratogenicity seen, except IUGR was common. So small for birth weight babies are common, SGAs was common, and that is the only concern we have about metformin. Of course, many of them did
in fact, I would, sorry to interrupt you. In fact, I wanted to ask you this only, that women who are, either over diabetic, my concern is only about the congenital malformation. Okay, so women who are on PCOS on metformin, if at all they find, you find that them GDM positive, they are screen positive, you continue with it.
Now you have got, now yes. Madam, you have got official guidelines from European organization.
Yes.
That it can be continued till delivery, and on the basis of that, we are not protected.
Yes.
There is one good organization has allowed it, and will continue. DIPSI last year has come out with 2023 guidelines, and we also now say that from 12 weeks we can instead of 20 weeks we can start, even if it is pure GDM.
Yes, exactly.
The only contraindication for metformin is placental insufficiency or any vasculopathy or preeclampsia, hypertension. Such women where there is a chance that these women might land up into trouble, and IUGR is more common in these women if you have associated vasculopathy or placental insufficiency. So such patients should be it is contraindicated.
I'm just clarifying this for the house, because even when I present my topic on this hyperglycemia and pregnancy, I have been projecting that slide at the even NHM and Government of India guideline also say that metformin and insulin are equally effective. And now that it has been proven beyond doubt that, the teratogenicity is not significant. So that is what I wanted to hear from you, so that, all the attendees, they do not have any doubt about it. Thank you so much. Dr. Deepika, if you have.
No, ma'am, sir has practically elaborated all essential points, and his expertise and his valuable inputs will be very helpful for managing patients.
Sneha, I have one question.
Yes, please. And Dr. Moshmi, you can also please ask some queries. We have endocrinologists to help us. Yeah. Vidya, you're not audible. Your network is not supported.
I was talking about the hypoglycemia. So, patient, and then how you let it.
She is not audible, I feel, Dr. Vidya. So her question, if I can gather, is about hypoglycemia. I'm not sure whether she's asking about neonatal hypoglycemia or maternal hypoglycemia. So I'll try to clarify both of them. Neonatal hypoglycemia, when we say when the blood glucose is less than 40. Unlike in adults, we say less than 70 and 54. In babies, we say less than 40. And it has to be this common in the neonates when the blood glucose remains uncontrolled. So if some baby is getting neonatal hypoglycemia, that means the maternal blood glucose at the time of delivery, when you cut the placenta, was high, and which has caused hyperinsulinemia to baby and causing neonatal hypoglycemia. Now, second part of it, that if some women who's on high dose of insulin or not metformin won't cause hypoglycemia to that extent, but in mothers, if they're on very high dose of insulin, if they skip meal, if they keep fasting during Navratra and all these things, in such situations, it is likely that they'll end up into hypoglycemia. But this is very important to know by every one of you. Hypoglycemia is very well sustained during pregnancy versus in a non-pregnant state. And it is not of too much of concern especially in the pregnant women, hypoglycemia. But if you go very, very tight control of someone's going only 40s and 50s, then there are chances of having IUGRs. But most of the studies have clearly shown that the tight blood glucose is good for the babies and it does not precipitate IUGR or other things. So hypoglycemia is not of much concern. I feel there is a question in the chat box about the vomiting after taking 75-gram glucose. So in such cases, you can give antiemetic and next day, and you can again. But if this vomiting is after it means say after 1.5 hours or so, 1 hour or so, then you can certainly continue. But if it is within half an hour, you should certainly. I think someone already answered that. So Sneha madam has already answered that. So yes. So hypoglycemia, I have covered both maternal hypoglycemia as well as neonatal. Frequent small meals will prevent hypoglycemia. There was one more question from someone, ma'am, or?
Dr. Vidya Thobi. I think she's not available for discussion. But anybody wants to make any comments or have any doubts? It's welcome. Any of your comments are welcome. I think you have clarified all their doubts. So thank you so much for accepting our invitation and of course delivering your best. Thank you so much. And Monica, are you here? So I would just conclude by saying that in fact we have a spectrum of talks today, right from screening screening, that is universal screening, and then of course the monitoring and management of hyperglycemia in pregnancy, especially the advanced gadgets, what Dr. Hema Divakar has talked about, also the medical nutrition therapy and role of ultrasound in the management of hyperglycemia in pregnancy, and of course the expert of the field, Dr. Sunil Gupta, the endocrinologist from Nagpur. So we are very happy to have a focused discussion on hyperglycemia in pregnancy. And thank you so much, all of you, for accepting our invitation and trying to clarify almost all the doubts, I would say. Thank you so much, Dr. Sunil Gupta, once again from our side. Thank you so much. Monica?
Thank you, ma'am. Thank you so much for giving me an opportunity to coordinate this program. I would like to thank Dr. Jagdi madam and Dr. Khanna madam to join us for the inauguration as guest and guest of honor. I would like to thank Dr. Saxena madam, Dr. Hema Divakar ma'am, Dr. Uday Thanawala sir, Dr. Sunil Gupta sir, and Dr. Vidya Thobi madam for being the faculties who have guided all through the program, and the delegates have had a lot of take-home messages from their lectures. I would also like to thank all our chairpersons for today for their excellent inputs and accepting our invitation at the last minute. I would like to also thank Sahiti for the technical help. Thank you, everyone, and we wish you, ma'am, all the very best, and be rest assured